Good morning, everyone. We welcome you all to the first day of this 2 days webinar on anaerobes microbes of the millennium by Anaerobic Forum India and AIMS ASM 2021, jointly organized by the All India Institute of Medical Sciences, New Delhi, and the American Society for Microbiology. This webinar aims to highlight different aspects of anaerobes through its various sessions. We have with us today renowned professionals from across the globe to share with us their experiences addressing various topics to cover the vast spectrum of anaerobes. We hope this webinar will be useful to all of you and you will derive inspiration to work in the field of anaerobes. With this, I invite Dr. Rama Chaudhary, the organizing chairperson, for her welcome address. Can I have the CV slide for Dr. Rama Chaudhary, please? Dr. Rama Chaudhary, Professor and Head Department of Microbiology, All India Institute of Medical Sciences, New Delhi, India. Ma'am is the International Ambassador of American Society for Microbiology to India and a member of ASM Ambassadors Leadership Circle. She has been awarded by many awards and honors like the Atal Swasthya Bhushan Samman 2019, Indian Association of Medical Microbiologists Endowment Award, Dr. R. Sen Gupta, and Dr. A.M. Saoji Memorial Prize Gold Medal Award, and many more. She has guided more than 30 MD, PhD, and DM students with over 200 research publications in journals of international repute. Her areas of research include the anaerobic bacteriology, special bacterial pathogens like the Mycoplasma rickettsia, antimicrobial resistance, Lyme's disease, human microbiome, metagenomics, probiotics, and bacteriophage. Now I request Dr. Rama Chaudhary to kindly welcome the guest.
So good morning, everybody. I'm so happy to have this 2 days webinar, which is organized by All India Institute of Medical Sciences in collaboration with American Society of Microbiology. I also welcome our dignitaries, our chief guest, Professor Dr. Randeep Guleria, Director of AIMS New Delhi, our guest of honor and my mentor, Dr. Usha Gupta, and also many national and international faculties who will be giving their deliberations today. In fact, the anaerobes have been a real challenging field in the times of, especially in today's time. And the world of anaerobes is fascinating so much that all the infections, as well as many environmental microbiology areas, are actually where the anaerobes are playing very, very important role. In fact, in earlier times, when Leeuwenhoek was doing his experiments, he described the living forms as a kind of living animalcules. And later on, it was seen by Pasteur that actually it was a Clostridium butyricum. And in fact, it was around 200 years after this discovery was made. And it is so surprising that even today, after so much of expertise available these days, we are still challenging to grow anaerobes. Now we are in the 21st century. Our knowledge about anaerobes is still limited and we are growing, mainly because of their tedious requirements during culture. Only because of the availability of MALDI-TOF, Wojtek, and other identification system, the things have become simpler and we are able to give report of identification of anaerobes much earlier than the time we used to take in olden days. I also would like to say that the topic anaerobes, the microbes of the millennium, is very important because with the next generation sequencing, the microbiome is becoming important. And we have come to realize that anaerobes are playing most important role in our well-being. In fact, it has been seen that this knowledge, which is available with the microbiome, is now used in fecal transplants and also probiotics in many conditions of gut. In addition, as I said, that the industrial and environmental application of anaerobes like effluent treatment, fermentation, enzymes, biochemicals are all being explored because of the availability of newer techniques. So we planned this 2 days webinar with an aim to encourage the attendees to take up this fascinating branch of anaerobes. In fact, the Anaerobic Forum of India has just been made in January 2021. And with so many young faculties and scientists who were keen to help to grow this particular field, we decided to hold this webinar in March. And American Society of Microbiology kindly gave us permission to do that. So therefore, we are very happy that we have more than 1,000 participants who have registered for today's event. And we have wonderful topics which have been selected by the scientific committee, which are going to be covered today. So once again, warm welcome to all our participants also who are joining us from different parts of the world and from different areas of India. I urge all our participants to carefully listen to the talks of the webinar, as we have a quiz after the session and the winner will be awarded. So with that, I really welcome all of you once again. Thank you so much.
Thank you, ma'am. Can I have the CV slide for Dr. Pallavi, please? Now I invite Dr. Pallavi. Sir is Professor in Charge Bacteriology Section, PGI MER Chandigarh, and the current President of Indian Association of Medical Microbiologists. Sir has guided over 150 theses and dissertations with more than 250 publications of international repute. Sir has also been awarded with the Best PG Gold Medal Award from PGI, Dr. S.C. Agarwal Memorial Oration, the most prestigious award of Indian Association of Medical Microbiologists, and many more. Sir has the areas of interest of Sir include antimicrobial chemotherapy, staphylococcal infections, sepsis syndrome, anaerobic bacteriology, healthcare infections, medical education, and teaching technology. Now I request Sir to kindly address the gathering.
Thank you very much, Professor Randeep Guleria, the chief guest of today's function. Dr. Usha Gupta, one of the senior most persons in the field of anaerobic bacteriology. Dr. Rama Chaudhary, who is the brain behind this webinar for 2 days. And all the delegates who are attending this webinar for 2 days. It gives me extreme pleasure to be associated with this anaerobic forum webinar for this year. It has been rightly named anaerobes, which are the microbes of the millennium. Truly speaking, if you look at it, anaerobes are really enigmatic organisms which have not really received the amount of attention that it deserved to have. But they are extremely important. Just look at the anaerobic organisms. About 3.5 billion years back, the first life form which evolved on this earth were the prokaryotic organisms, and definitely they were the anaerobic organisms, because at that time we didn't have oxygen in the environment of earth. And these anaerobes, which ultimately evolved into cyanobacteria and subsequently multi-cellular life forms, and finally man. These anaerobes, they have seen the whole history of life on Earth, and therefore they have remained as the biggest component of the living world on Earth. Truly speaking, you look at anywhere on Earth, whether it's the non-living environment or the animals, including man, the anaerobes predominate everywhere. Just look at our own body, you will see that the anaerobes, they outnumber, or rather the bacteria, they outnumber our eukaryotic cells in a ratio of 10:1. And nearly 95% or more of those bacterial species that we host in our body, these organisms are anaerobic organisms. Interestingly, these anaerobic organisms, they are not only passively present in our body, If you look at the density of the organisms in our gut of the order of 10 raised to the power 12 to 10 raised to the power 13 organisms per milliliter or per gram of our colonic contents, you will hardly find any place on earth outside the human body where the anaerobes are there in that huge number. That shows that our body has created an environment and hosted a huge load of organisms, predominantly anaerobes, in our body, in our own interest. The anaerobes, they are extremely important to maintain the homeostasis of our body. They have a role to play in every aspect of our body, in health or in disease. If you look at it in the development of our immune system, anaerobes, they have a very, very important role. Now, there have been lots of difficulties in studying the anaerobes, particularly because these organisms are rather demanding in their either nutritional or in their gaseous requirements, and the environmental 21% oxygen that we have, it's rather toxic to anaerobic organisms. And these difficulties have really led to rather suboptimal attention to the role of anaerobes for a long, long time. Even to the clinicians, if you see that we usually, the microbiologists take a much, much longer time to grow the anaerobes, to identify the anaerobes, and the most difficult part is to carry out a susceptibility test for anaerobes. And the clinicians feel that it's easier to treat anaerobes than to wait for 2, 4, 8 days to get a diagnosis, because majority of the anaerobes have remained for a long time sensitive to my metronidazole. But these difficulties are gradually going away nowadays with availability of molecular technologies which can characterize organisms without them being cultured. Then with the availability of technologies like MALDI-TOF mass spectrometry, which can give you the identification of even an anaerobe in less than 5 minutes of time, and then availability of many other technologies, the world of anaerobes, they are unfolding in front of the whole mankind. These recent developments will definitely lead to much, much more importance for the anaerobes in the coming decade or decades to come. And I see that the anaerobic bacteriology has got a fantastic and bright future in the next decade. I congratulate all the attendees of this particular webinar, because this webinar will tell them the importance of every aspect of anaerobic bacteria, and you will get stimulated to know about anaerobes and also encouraged to work on the anaerobes. I thank the organizers for conceptualizing this webinar and carrying out this webinar in the interest of the whole mankind. Thank you very much, and Jai Hind.
Thank you so much, sir. Now I welcome our chief guest, Professor Dr. Randeep Guleria. Can I have the CV slide for sir, please? Professor Dr. Randeep Guleria, Director, All India Institute of Medical Sciences, New Delhi. Sir is a member of the National COVID-19 Task Force, Government of India, Empowered Group 2, created by the Prime Minister's Office for Multi-Sectorial Management of COVID-19, Joint Monitoring Group for the Pandemic and Outbreak Management of India. He is the chairperson of Clinical Research Group of ICMR for COVID-19. He is a member of many key committees, including the Joint Monitoring Group of Government of India on the advice about the pandemic influenza H1N1 outbreak and other outbreaks, the Scientific Advisory Group of Experts working on the Working Group of the WHO on Influenza Vaccines and Immunization, AMR control in India. Sir has been credited by the establishment of Department of Pulmonary Medicines and Sleep Disorders at AIIMS in 2011. He is the recipient of Padma Shri Award in 2015 in the field of medicine, Dr. B.C. Rai Award for the Eminent Medical Person, Times Healthcare Achievers Award in the Legends category, Doctor of the Decade by Indian Medical Association, Vision UN Sustainable Developmental Goals Ambassador by the Vision Divang Foundation, National Excellence Award, Lung India Award, Swasthya Bharat Samman, and he is the Fellow of National Medical Science Academy 2009. And he has also been awarded by the Association of Physicians of India EMERC Award for Chest Diseases in 1999. Now I request Sir to kindly address the gathering.
Thank you very much and good morning. Professor Usha Gupta, former professor and in charge in anaerobic and mycoplasma laboratory at the All Indian Institute of Medical Sciences, New Delhi. Dr. Pallav Ray from PGI Chandigarh. Dr. Rama Chaudhary, who is the force behind today's conference. Other senior faculty from abroad and from India who are part of this webinar. Delegates, ladies and gentlemen. At the outset, it gives me immense pleasure that the Department of Microbiology at the All Indian Institute of Medical Sciences, having partnered with the American Association of Microbiology, is jointly organizing this international webinar on anaerobes, microbes of the millennium. This is basically being done by the Anaerobic Forum of India 2021 and AIMS ASM 2021. And I'm also very happy to note that we have really an array of national and international speakers who are taking part in this webinar. To name a few, we have Dr. Itzhak Brook, Professor of Pediatrics at Georgetown University, Washington, DC. And I can understand that it's going to be pretty late in the night for him to log on at this time. So he has a vast experience in the field of pediatric infectious diseases and research interest in anaerobic infection. We have Dr. Joseph Soki, who is from the University of Stuttgart, Department of Clinical Microbiology, Hungary. And from India, we have Dr. George Varghese, who is from CMC Vellore. He's a professor and a head of the Department of Infectious Diseases. And of course, we have an array of people from PGI Chandigarh, from AIMS New Delhi, and from other organizations. So I'm sure it's going to be a great academic feast for all the delegates because very eminent people are participating in this webinar. Now, for a long time, anaerobes have been neglected as organisms. And since the first discovery by Louis Pasteur in 1862, they have never been able to sort of rise to the level that their aerobes were able to rise in terms of importance. But they had shown an increase in interest since 1965, and in the 1980s, a lot of interest in anaerobic infection was there in India. There were a lot of case reports of brain abscess, lung abscess, empymas, orodental infection, cutaneous lesions, and more recently from AIMS, Dr. Rama Chaudhary has published Clostridium difficile from intracardiac vegetations also. So a lot of interest started in the 1980s. It was led by stalwarts like Dr. Usha Gupta, who at that point in time really worked at AIMS and set up the anaerobic laboratory, which set the stage for anaerobic infection. We must remember at that point in time, it was more difficult to really isolate anaerobes as compared to what it is today. So this was a challenging time, and yet a lot of things were done as far as anaerobic infection in India was concerned to increase awareness. They've become more important now because of multiple reasons. First of all, there is a rising population of immunocompromised individuals, whether it be the elderly, whether it be people on immunosuppressant drugs, and therefore anaerobic infection have become more and more important. Also, with increased use of antimicrobial drugs, anaerobic infections have also become an important issue. And now there is increasing awareness among clinicians that you really need to provide cover for anaerobic infection in many diseases because they can lead to higher morbidity and mortality. For long, we have had metronidazole as a treatment of choice for anaerobic infection, and it has been very effective in treating anaerobic infection. But if you critically look at the literature over the last few years, clinical failure has been reported in some cases, even with metronidazole, and I think that is a cause of concern. Other drugs like carbapenems, beta-lactamase inhibitors, and clindamycin and other drugs have also been used for anaerobic infection. But we must keep in mind that there has to be a judicious use of anaerobes. Otherwise, we will have an issue of antimicrobial resistance as we are seeing with aerobes. and the emergence of so-called superbugs as far as anaerobes are concerned. Therefore, I think this is the time right now that we start looking at how do we have a judicious use of antibiotics even for anaerobic infection, rather than going down the path of what has happened as far as aerobic infection is concerned, with the huge emergence of AMR, which we're having a problem dealing with right now. This has become further sort of aggravated by COVID-19, because during the COVID-19 pandemic, although it's a viral infection, there was a huge use of antibiotics, and in many ways a misuse of antibiotics because of a worry of secondary infection. And therefore, this has led to people understanding the importance of Clostridium difficile infection and other infections which have risen as opportunistic infection during the COVID-19 pandemic. We're also aware that anaerobes, as Dr. Pallavi mentioned, play a very important role as far as the microbiome is concerned. And there is also now a huge interest in gut homeostasis in the microbiome. People say that now the next decade will belong to research on the microbiome, because the interaction of the human body with microbiome is becoming more and more interesting, both from our immune system and also from the point of view of various infections. So I think there is a lot of interest as far as anaerobic infection is concerned, and therefore I'm sure that this webinar will be of great interest not only to students but even to clinicians and researchers who have logged in, and they will understand the importance of anaerobic infection and how we need to develop better management strategies. I would once again like to really congratulate both Dr. Usha Gupta, who started all this journey at the All Institute of Medical Sciences, and now Dr. Rama Chaudhary for sort of continuing this journey as far as anaerobic infection is concerned. And I'm sure that this two-day international webinar will be a great success, and you will get a very positive feedback from all the delegates. So I wish you all the best, and thank you very much.
Thank you so much, sir. With this, now I invite our guest of honor, Professor Usha Gupta. Can I have the slide for ma'am, please? Ma'am is a pioneer in the field of anaerobic microbiology, mycoplasmology, and food microbiology. And sir, as sir rightly said, ma'am was credited with the establishment of anaerobic microbiology in AIIMS, New Delhi. And it would not be incorrect to mention that Professor Usha Gupta is synonymous to anaerobic microbiology in India. She was awarded the ICMR Research Award, the IMA Hari Om Ashram Award, and Lifetime Achievement Award in 2016 by IAMM Delhi chapter. She was also awarded the Fellow of National Academy of Medical Sciences in 1994. She was appointed the WHO short-term consultant for conducting food microbiology workshop in Indonesia and anaerobic bacteriology workshop in Myanmar. She also conducted the first All India Symposium cum workshop on anaerobic infections in man in 1981. She has published and edited more than 100 papers in national and international journals, and she has a lot of books over the topics of anaerobic infections and medical microbiology. Now I request ma'am to kindly share her wisdom with the gathering.
Dear colleagues, seniors and juniors, dear colleagues, both seniors and juniors. I wonder if there are any senior colleagues here today, but still I would like to welcome Dr. Guleria, Professor Rama Chaudhary, and Professor Pallavi, who have been here this morning. I started working at the All India Institute of Medical Sciences in 1968, and initially worked with known pathogens like Shigella, Salmonella, etc. But then I was looking for something more interesting and more challenging, and I spotted the anaerobes. As an undergraduate student, I only knew of some Clostridia, like Clostridium tetani, cause of tetanus, Clostridium perfringens, gas gangrene, and Clostridium botulinum for botulism. Beyond that, my knowledge was zero. Anyway, the non-sporing anaerobes came into the picture, and I started to work on these organisms without any help and without any support. I recall, both I and Dr. V.N. Bhatia started growing anaerobes after the working hours at the Department of Microbiology, AIIMS, New Delhi. We had no gases, we had no anaerobic jars except one, which was used for demonstration to the students. And we had no media, and we had no clinical specimens. So we started the work. I recall how we started the work with our own hands, with gases from the KIPS apparatus, one anaerobic jar, and a few specimens which were discarded in the routine microbiology laboratory for culture. And you can imagine what we got, nothing. Anyway, we slowly worked for 10 years and started getting more and more experience, starting with demonstrating the value of bedside cultures, anaerobic transport media versus the routine method of transportation of clinical material. And we started growing Clostridia. Dr. Betty Hobbs from London, she helped me a lot. And we did our first work on Clostridium perfringens from human material. Their serotyping, their role in the disease, food poisoning, and their so much other work. Gradually, we built up our knowledge and we started isolating non-sporing anaerobes, Peptostreptococci, Bacteroides, Fragilis, Bacteroides melanogenicus, and gathered enough material in 10 years on their role in clinical diseases, especially obstetrics and gynecology, orodental infections, pyogenic infections, post-operative infections, and also in their role in various research topics, till we came to 1981, where we had enough confidence and material to organize the first All India Symposium cum workshop in March 1981, 40 years from today, for 20 days, for 12 days, the whole symposium. It was well attended and it was published in a book form, which is available even today. After that, we started looking at the role of bacteroides in gastrointestinal infections. And since their numbers were much more than what the E. coli numbers were, and we tried to demonstrate whether they were enteropathogenic. And one of my postgraduate students, Dr. Ravi Jotwani, worked on the role of bacteroides in gastrointestinal diseases. And he tried to demonstrate intestinal toxicity in rabbit ileal loop models. Of course, we were not very successful, but then we started working on their antimicrobial sensitivity patterns and discovered drug resistance at that time, which Dr. Guleria has spoken about. And we tried to show how we could get over the drug resistance in anaerobic organisms. We also tried to expedite the identification and reporting of anaerobes in clinical diseases. And we worked on nervous system, brain abscesses, doing gas liquid chromatography for rapid diagnosis so that we could help the clinicians at the right time. I recall, I must share with you one incident in which I was called in the middle of the night to give my opinion on a sample of clinical material taken from a patient suffering from gas gangrene-like symptoms. And what I discovered was that there were no Clostridia, but only Peptostreptococci. And that saved the limb of the patient because no amputation was done, and this patient was cured with extensive palliative surgery. We also emphasize the role of hyperbaric oxygen therapy in these cases, and this facility was available at that time in the Wellington Hospital and in Bombay. And then subsequently, after doing all this kind of disease work, I am so happy this morning that Dr. Rama has taken up the subject 40 years after I organized the first symposium and workshop, and subsequently 4 other workshops till 1984. Thank you, Rama, and I'm very happy that this millennium is going to be of anaerobes. Once upon a time, the whole world was anaerobic. And I think the right time has come when we should give the due importance to the anaerobic microbes, which are so many more times in the body than the aerobic and facultative anaerobes. Thank you, Rama, and I'm grateful to the AIIMS for the support they have given, and also for reviving this subject after so many years. Thank you.
Thank you, ma'am.
Thank you so much, ma'am. Rightly said, ma'am. It's the right time that we give the due importance to anaerobes now. So with this, we move on to our scientific session, the first session on emerging anaerobic infections. The chairpersons for this session are, can we have the slides? Dr. Rama Chaudhary, Professor and Head Department of Microbiology, and Dr. Tanu Sagar, Associate Professor, Department of Microbiology, Maulana Azad Medical College, New Delhi. Ma'am has more than 20 publications in both national and international journals and has reviewed articles in the journals of international and national repute. She has authored chapters in international books. She's the treasurer of Indian Association of Mycoplasmologists and a committee member of Anaerobic Forum of India. She has been awarded with the Best Poster Awards in Delhi chapter, and her areas of research include bacteriology, mycology, antimicrobial susceptibility, and infectious diseases. Now I request Dr. Rama Chaudhary and Dr. Tanu Sagar to kindly chair this session.
So in the first session, I'm so happy that we are going to have our international speaker, Dr. Isaac Brook, who is a professor of pediatrics from School of Medicine, Georgetown University, Washington, DC, USA. He has done pediatric residency in Kaplan Medical Center in Israel and master's degree in pediatrics from University of Tel Aviv in Israel. He did his fellowship in adult and pediatric infectious diseases at the University of California, Los Angeles. He's also professor of pediatrics and medicine at Georgetown University, Washington, DC right now. He's post-chairman of Anti-Infective Drug Advisory Committee of FDA, chairperson of HIV AIDS Committee in 1987 and approved the AZT. His professional achievements are so many that if you just Google his name, it is pouring with publications, with book chapters, and I'm so happy that he accepted our invitation to be here today. He developed the treatment guidelines for various pediatric infectious diseases. He authored 6 medical textbooks and over 135 medical book chapters. There are over 700 publications, and I think there is no area of anaerobic bacteriology, especially in pediatric diseases, which he has not covered. An editor, associate editor, and member of the editorial board of several medical journals. His main area of interest, as I said, is anaerobic infections, special interest in sinusitis, tonsillitis, and also infection following exposure to ionizing radiations. He has been awarded, he has been the recipient of 2012 Conley Medical Ethics Award of the American Academy of Otolaryngology, Head and Neck Surgery. And as I said, he's editor of 3 and associate editor of 4 medical journals as well. So thank you so much to Dr. Isaac Brook for accepting our invitation. And we are all looking forward to your talk today. I request all the participants to keep the volume of their devices high, because in fact, it is a late night there and he still agreed to give his deliberation, but there may be low voice notes. So please keep the volume high on your devices. Thank you so much and welcome to Dr. Isaac Brook, please.
I am pleased to be with you tonight for me and this morning in participating in an important seminar on the anaerobic infections. As you can hear, I have a very weak voice, and this is because I don't have vocal cords. I suffered from throat cancer, and I had laryngectomy 13 years ago, but hopefully you can understand me. And I indulge you to try to adjust the volume on your devices so that you can hear me well. Anaerobic infections are a very, very predominant type of infection, and I was fortunate to be introduced to them by the late Dr. Sidney Feingold, who is my mentor, and introduced me to all the research and work I've done on anaerobes. Anaerobic infections originate from the body mucous membranes, where anaerobes outnumber aerobes in the ratio of the 1,000 to 1 to 10,000 to 1, depending on the location. And if you know the source of the infection, you can make an assumption and know where the organism originates and what organism you can find. Anaerobes are outnumbering them in very, very high numbers. And if you look at the gut flora, this is the ratio of obligate anaerobes to aerobic or facultative organism such as E. coli. And depending on the cavity of the body, you can see the ratio between the aerobes and anaerobes. In the skin, we have P. acne and Peptostreptococci. In the oral cavity, we have Prevotella, Melaninogenica, Fusobacteria. And the GI, depending on the location, we have B. fragilis group Clostridia. And then in the genital tract, we have Prevotella, PVI. such as enzyme and toxin and endotoxins. The lytic enzyme enable them to spread through different tissues, and the capsule allows them to evade phagocytosis and cause abscesses throughout the body. There is a very interesting study that we showed how the organism that are the Bacteroides fragilis family, when they live in the GI tract as normal flora, most of them contain villi and very few contain capsule. But when they get into the peritoneal cavity, those of them that can produce a capsule survive, while those that don't are eliminated by the body defenses. But when they invade the blood and cause bacteremia, they lose their villi and still maintain their capsule that allow them to evade engulfment by the body white cells and other defenses. So it's interesting to watch how the organism change their features when they move from one body location to the other and maintain the virulence. We do see a very interesting cycle in anaerobic infection, and you can see it in the respiratory tract, in otitis or sinusitis, where the initial 10 days are marked by viral infection that creates the infectious process. In the first months or so, you have acute infection, which are caused by aerobes such as strep pneumo, Haemophilus, moraxella, and as times go into chronicity, we would see organisms such as Prevotella, Fusobacteria, and Peptostreptococci. We see the same by abdominal infection, where the initial stage is by peritonitis due to Escherichia coli, and as time progresses, we see the abscesses appear, and the aerobic stage is also associated with bacteremia, and the abscess stage by the importance of Bacteroides fragilis, which is the work that was done by the late Dr. Bartlett in UCLA. And this is what we see in the infectious process in the respiratory tract. Initially strep, Haemophilus group A strep. Then we see the microhalophilic organism, and eventually the strict anaerobes that cause the chronic respiratory infections such as sinusitis, otitis, tonsillitis, and mastoiditis, and all other head and neck infection. We observe this transfer dynamic in several patients with otitis media when we follow them by cultures over time, and you can appreciate how strep pneumo initially disappeared and was changing into fuso and peptostrep, and the same thing in the second patient, where Prevotella appeared after about a week, and peptostrep later on, and that's partially also because of the treatment with antibiotic that selected those anaerobic organisms. Also, in otitis Here is a microbiology of suppurative stylaltinitis. Here too, the parotid gland, the submandibular gland, and sublingual one. Each of them have unique microbiology that is similar to the oral flora. And the same is true for dental infection. Periapical abscesses. The majority of organisms are anaerobes, while very few aerobic organisms are found there, and they are responsible to those chronic sinus infection, where the organism progress from the periapical abscess into the maxillary sinus, and you can appreciate that it's the same organism in many cases. Here the views up in both places, the Prevotella. There are some differences in microbiology, but there is similarity in the majority of patients, showing again how the infection progresses. Studies in the sinusitis again, including those done in many countries around the world, shows that predominance of anaerobes in over 50% of the patient in the majority of cases. So they are very important there as well. The explanation for the predominance of anaerobes in chronic infection is that changes in oxygen tension in those locations. In acute infection, the PO2 is high that support aerobe, but it's a reverse condition. As the infection gets chronic, the sinuses are obstructed, and that growth allow the growth of a anaerobic organism. Also in chronic head and neck infection, subcutaneous one, that emerge usually after head and neck surgery, we see the same predominance of those organisms that are found in all of those locations. One area where we did a lot of research is in tonsillitis, and there is more evidence today that tonsillitis is a mixed infection in many conditions, where aerobus strep and anaerobus puzo and bacteroides, and sometimes viruses as EB viruses can play a role. Let me show you some evidence for that. First of all, we know that anaerobes may play a role in Vincent angina. We know that we find them in peritonsil abscesses. There is an in vivo synergy between them and strep. And when you look at the number of organisms and most of the anaerobe in chronic infection become encapsulated. Abscesses here. There are 5 anaerobic tonsillar abscesses and only 2 aerobic abscesses. The predominance of group A strep was only found in 4 of those 16 abscesses, so peritonsillar abscesses are anaerobic. And here are the studies where we showed an increase in antibodies in a patient who developed peritonsillar abscesses when we took cultures, when we aspirated the pus and looked for IG, the antibodies IgG against Fuso and Prevotella, we found a significant number of those patients that developed those antibodies, showing that those 2 organisms, at least those, may play a role in the formation of the abscess. And when you treat patients who have mononucleosis with metronidazole, you can appreciate that those who get treatment with metronidazole get a febrile much faster than those who got no treatment. I'm not advocating the use of metronidazole in mononucleosis, but it does make sense to use them in patients who don't respond to treatment and may seem to be in a more serious condition. And here is some data about what happens in patients with recurrent tonsillitis. Those patients, in addition to the presence of large number of anaerobes in their tonsillar culture, the majority have the enzyme beta-lactamase, and that beta-lactamase may explain one of the explanations why penicillin can survive treatment. Why group A strep can survive treatment with penicillin because of the production of the enzyme beta-lactamase by Staph aureus and Prevotella and some Fusobacteria. And there are studies that show that agents such as Clinda or lincomycin seem to be more effective in the treatment of group A recurrent tonsillitis. Here is the data with cervical lymphadenitis, where you can appreciate the predominance of anaerobic organism. Aspiration pneumonia, lung abscesses are known caused by anaerobic organism. The initial studies were done by Dr. Feingold and Bartlett, and we found the same thing in aspiration pneumonia in children. Large number of Fusobacteria and Prevotella and even some Bacteroides fragilis in those patients, and the same happens in empyema. The same kind of flora and lung abscesses and also subdiaphragmatic abscesses in those patients. Patients with female tract gastral infection also can be anaerobic. Post-abortion sepsis, pubertal sepsis, tubo-ovarian abscess, endometritis, vulvarovaginal abscesses, as well as chorioamnionitis. Intra-abdominal infection are classical anaerobic lesion. As complication of appendicitis, peritonitis, liver abscesses, subphrenic abscesses, and other interabdominal one including wound infection following surgery or trauma. That's because the gut flora spills over into the peritoneum, and studies that looked at abdominal infection show that anaerobes account for 50% and aerobe for 48. Predominant one are E. coli and Enterococci, and predominant anaerobe are the Bacteroides fragilis, Clostridia, and Peptostreptococci. And the organism that we found in patients who had perforated appendices, as well in patients who had wound infection, had the same type of flora as I showed you earlier. The same is true for perforated diverticulitis, where you have the gut flora spill over the peritoneum. There are some classical infections for neonates. Scalp infection who get fetal monitoring while they are in the birth canal. The vaginal flora is introduced there. Neonates that aspirate or develop omphalitis or bacteremia, botulism and necrotizing enterocolitis. There is also data that support the role of some anaerobes there. It's very interesting to look at the role of anaerobes in skin and soft tissue infection, including decubitus ulcer. If you look at the body, around the oral cavity and breast, nipples and fingers,
Thank you, sir. Can we have the slide for the next speaker, please?
Good morning, everyone. I'm Dr. Tanu, and the next session will be on antimicrobial resistance in anaerobes. So we are talking about antimicrobial resistance as such. We know that it's rising every year and every decade. But what about the antimicrobial resistance in anaerobes? Do we really know much about it? So for this session, it's my pleasure to invite our next speaker, Dr. Soki. He is from Hungary. He works in the Department of Clinical Microbiology. His area of interest is in antimicrobial resistance mechanism of anaerobic pathogens, and he has number of awards and honors under his name. He is a member of European Society of Clinical Microbiology and Infectious Disease, and he has a good number of papers in both reputed journals with impact factor of more than 100 and with citation of more than 1,000. And he's also editor of reputed journals like Anaerobes and Frontier. And he's also a member of European Society of Clinical Microbiology and Infectious Disease. So I welcome you, sir, for the next session. And I'm sure this session will going to be an eye-opener for many clinicians and as well as microbiologists. Over to you, sir.
Yeah, thank you, Dr. Shagar. First of all, I would like to thank the invitation for this webinar, and I will talk, as you mentioned, about the anaerobic drug resistances. So my talk will be distributed in 3 parts. So first, I will present some general introductory information, then present some figures about the antibiotic resistance levels of anaerobes, and then the main topic of the antibiotic resistance mechanism will come. So just to introduce anaerobes, so we know that they just can gain energy from the fermentation of the organic compounds, and this way they gain redox intermediate when if they are exposed to oxygen, they generate reactive oxygen species. So it is behind if they can reduce this reactive oxygen species level, then we can speak about oxygen tolerance. So there are some different levels of oxygen tolerance with anaerobes. So there are obligate anaerobes that cannot grow at atmospheric oxygen. There are facultative anaerobes that can use oxygen because they have electron transport chains to reduce the oxygen. There are aerotolerants that survive oxygen but cannot use microaerophils that can use micromolar oxygen. And there are so-called nanorobes. I don't know if you are aware of that can also grow on nanomolar oxygen levels and have electron transport chains from some organic materials that can reduce oxygen. It is my favorite picture about the phylogeny of the main bacteria phyla, and I just want to show you that anaerobes come from all the cultivable phyla of the bacterial kingdom, and I showed different anaerobes belonging to different phyla in the domain of bacteria. So from alpha proteobacteria, from gram-positive, low GC gram-positives, and high GC gram-positives also. And there is the main phyla of Bacteroidetes that may um, uh, give rise or harbor a lot of oxygenic anaerobic pathogens. So their biology also affects the antibiotic resistance mechanism. We will show it later. So some words about the antibiotic susceptibility testing of anaerobes. We need that they require a long time of cultivation to get final results. It may take 7 days. So sometimes it is too long for initiate a good therapy for the patients. So regular antibiotic resistance studies are needed to reveal the temporal and spatial situations at the hospitals to facilitate empiric therapy. And sometimes, so this way we will know the situation with the antibiotic resistance in special places, but sometimes individual ISTs are also needed, like in life-threatening infections, sepsis, and infections at otherwise sterile sites. Which are the methods that we can use for ISTs of anaerobes? So the surveys, we use the reference method of agar dilution. By these, we can detect the resistance situation. Also, the Brose microdilution method is can be used. And I recommend the gradient test, the E-test for individual ISTs. And in Europe and the USA, there are some regulations how to implement these antimicrobial susceptibility tests. So it is the CLSI and the UCAS. You may find some references for that. So there are recommendations to carry out the ISTs and to interpret them. In the 1970s, there were studies that found that this diffusion is not a very good method to detect IST among anaerobes. But now we just speak about that again, that this diffusion can be used for well-growing anaerobes. There were some publication earlier for this, and the UCAS, the European recommendation body, now just works on how to introduce again this diffusion into clinical ISTs. So yes, if we got the antimicrobial resistance data, we can initiate therapy, but we should be aware of the intrinsic resistance among anaerobes. So all anaerobes are resistant to aminoglycosides because aminoglycosides need an electron transport change to pick up, to transfer these antibiotics into the cytoplasm. So because the lack of electron transport change, aminoglycosides are not taken up by the anaerobes, so they cannot act. All anaerobes are also resistant to aztreonam, fosfomycin, and first and second generation fluoroquinolones. And there are species-dependent intrinsic resistances for the aerotolerant bacteria, as Actinomyces and propionibacteria for metronidazole. Rifampicin cannot be used for Fusobacterium necrophorum mortiferum. And for Clostridia and Clostridioides difficile, there are different levels of cephalosporin intrinsic resistance, and macrolides are not active against Fusobacteria. So some table about the change in antibiotic resistance values against anaerobes. So I show in this slide the USA and the Europe resistance data for anaerobes. So we can see that ampicillin resistance is very high. The beta-lactamase inhibitor combinations, there were some increase in their resistance during the run from the early 1990s through 2000 and 2008. Cefoxitin is also increasing, and imipenem is low, but maybe increasing, but we cannot be sure about it. Clindamycin is also increasing. So tetracycline resistance is like ampicillin, so it is very high. Metronidazole resistance is very low as for carbapenems, and we cannot be sure if it is increasing or what. And the fluoroquinolone resistance values we cannot know, or ciprofloxacin is not very active, but moxifloxacin is very active. These studies were regularly done in the USA and in 10 days, 10 years increments in Europe, but now they just stopped, and we can rely on national susceptibility studies in these countries that I highlighted. These were the situation for Bacteroides, and for other anaerobes, there is a similar situation, but with less high resistance values. So penicillin G, there is some resistance, for example, mainly in Prevotelle. The beta-lactamase inhibitor combinations are very good. Cefoxitin resistance is low. Imipenem resistance can be neglected. Also, clindamycin resistance is increasing. Tetracycline resistance can be high, and metronidazole is also a good agent against them. We can say that the antibiotic resistance levels just correlate with the significance of these anaerobe groups, and this way Bacteroides has the highest number of resistance mechanism and resistance levels, and this may be because they are the most abundant anaerobes in the body, and they just have to an opportunity to communicate with each other in the cell can communicate with each other and spread the antibiotic resistance. So antibiotic resistance mechanism can be mediated by different processes highlighted in this picture. And when we talk about antibiotic resistance mechanism, we mainly mean the effector genes, and we can also speak about the regulation of these effector genes that can be mediated by different methods I highlighted here. And also we can examine the spread of this resistance mechanism as vertical way and as horizontal way, including the mobile genetic elements. So I mentioned that anaerobes are scattered around the phylogenetic tree of bacteria, but for anaerobes we can just compose some general aspects. So regarding the mobile genetic elements involved in their antibiotic resistance, we should mention the plasmids, the IS element and transposons, and the so-called conjugative transposons and mobilizable transposons. So IS elements are selfish mobile genetic elements that have inverted repeats at their end and only code for a transposase, and this mediates their transfer in the cell. And transposons are similar mobile genetic elements. But there are some integrated mobile genetic elements among anaerobes, the mobilizable transposons and the conjugative transposons. These mainly can differ just the conjugative transposon can mediate their self-transfer by the similar machinery as for plasmids that can carry out conjugative processes. So mobilizable transposons don't have these transfer genes, but also have a gene, the mobility gene, that enters them, that may allow them to enter to the conjugation process. So these are transposons. We say that they are conjugative or mobilizable. These are integrated in the chromosome as transposons by the help of excision genes that can excise, and by the help of the transfer genes, they conjugate into susceptible host, and they just can integrate into the chromosome. So these are the processes they can spread. And just discussing the resistance mechanism of the anaerobes. So I will start with the Bacteroides and the beta-lactam resistance of them. So we know quite some genes about that can mediate beta-lactam resistance of Bacteroides. These are beta-lactamases, and to mention them, they can be the SEPA gene. There are some SEPA-like genes among Bacteroides, the CBLA that is specific for Bacteroides uniformis, the CFXA gene that is residing on a mobile element, a mobilizated transposon, and there is the CFA gene that codes for carbapenem resistance, and it is a metal beta-lactamase. All the other genes are class A2 genes. And these bottom figures are just highlighting our experiments with detecting these resistant genes. And I just extract the message from this that for SAPA, the resistance is so we can found resistant and susceptible strains with SAPA. So I will explain this phenomenon. So SAPA seems not quite very linked to the resistance. For cefoxitin, we can just experience a shift with CFXA positive strains towards the resistance values, and for imipenem, there is a good occurrence of the CFA positive strains in the resistance values. So in this order, these genes can mediate a better resistance by their action as a beta-lactamase to these compounds. So cefoxitin resistance, I mentioned that it is located on a mobilizable transposon, the CFXA gene here, and it is regulated by an IS element. And the most important thing is highlighted here. So Bacteroides have a special promoter structure highlighted here. For a good cefoxitin resistance mediated by CFXA gene, there is insertion element insertion up to the upstream region of the CFXA gene, and it completes a good promoter. So with a good promoter, the expression is higher, and therefore the resistance is also higher. But as I mentioned, there is just a little shift with CFXA positive strains toward the resistant values. So why it is? We also revealed that there are some penicillin binding proteins that cannot be inactivated by beta-lactam compounds up to the 256 MIC values. So they can mediate in this presence of these inhibitory reactions of the antibiotics. They can mediate the survival of the cells. And maybe we didn't examine, but maybe it is not just true for the cefoxitin resistance, but for the other simple beta-lactamases as penicillins and cephalosporins. So we can see that high ampicillin MICs can be obtained when there is low beta-lactamase activity, like for low MICs in the strains. So carbapenem resistance is my main topic. I mentioned the CFIA gene, that is a metallo-beta-lactamase gene. Its presence in Bacillus fragilis population is 5 to 10%. And the Bacillus fragilis population is 1 to 2% resistant to carbapenems, and is caused by IS element, and some non-fragilis bacteroides can be also resistant to carbapenems. So what is causing the CFIA resistant gene to be active? It is also again an IS element. I highlighted some figures here. So the jumping of the IS element to the upstream region of the CFIA gene in the susceptible strain can convert the susceptible strain to a resistant one, because they they will provide a good promoter for the CFIA gene, and it can be detected by PCR methods. The CFIA gene's upstream region is very conserved, so we can design primers here and here. And if it is an insertion element there, we got a higher PCR product. It is showing that this first part is showing that I mentioned. So this is the IS element structure. It is the start codon of the CFIA gene, and the promoters can be detected in the IS elements that drives the CFIA expression very high. The CFIA gene is located on a DNA segment that is characteristic for CFIA positive strains, and sometimes there is some insertions. So these show the insertion of insertion sequence elements to the upstream region of CFIA gene, and there are so-called with the GNAT and VAT-D genes, or GNAT and XETG genes, that can be a toxin antitoxin addiction system gene that we now hypothesize that can be involved in also in CFIA resistance regulation. So, but for intermediate strains, sometimes we experience this phenomenon called heteroresistance. So if we use an e-test, then we got the inhibition zone, and in the inhibition zone, resistance colonies appear. So it is called heteroresistance, and it can be mediated by the CFIE gene's own low activity promoter to switch on the CFIE genes in these colonies. And they show also these heterogeneous phenotypes that can be recorded by the so-called population analysis profiles. So there are some subpopulation of resistance strains in the among Bacterias fragilis strains. Also, the Bacterias fragilis population is divided into two divisions, the CFI positive and CFI negative divisions. This can be differentiated by several typing methods. And the CFI positive population doesn't harbor the SEPA gene. The CFI negative populations harbor the SEPA genes. And with Maditov MS, we can also differentiate between these two groups. For clindamycin resistance, we have earlier studies, not very well studied in these years. The main mediator is the RMF gene, which is methylating a specific adenine residue in this 23S RNA of the ribosomes, and they can be resided on transposons. And the transposon IS elements serve with promoters from that. These transposons can be allocated on large plasmids, and sometimes some mobilizable transposon resides in conjugative transposons. And the main, we detected some clindamycin resistant gene in our population, and you may see that in the resistant population, ARMF is enriched. For metronidazole resistance, I mentioned the reactive oxygen species in my introduction. So the reduced cofactors also can reduce the nitro group of the metronidazole, and it is further reduced to nitroso compounds, which can cause DNA damage. And we also should mention that there is oxygen in during the action of metronidazole. This one electron from the nitro radical group can be taken by oxygen, so the metronidazole cannot act. So, so it is important for metronidazole ASTs that we should not include. We should work in good anaerobic conditions, because they will show false resistance. So the metronidazole resistance can be mediated by some mechanism that alter the redox cycles in the cells, and some nitroreductases or efflux pumps or DNA repair mechanism can be also acting. And the most best known examples for this reduction enzymes is the NIM genes, that have several types and which can show 60% similarity among them. And they can be resided on small plasmids or in chromosomes. And sometimes the NIM gene and the activating IS element, it is also needed here to express the NIM genes, is sometimes conserved. And these NIM genes can be present in other anaerobes, and we have experienced or demonstrated that the situation, despite the insertion sequence element presence, the situation is not very similar to the CFIA genes, so it needs to be further investigated. So some recent experiments about the metallurgical or resistance in southern countries, we had some resistance strains from Kuwait, and we examined the resistance mechanism. It was mediated by the NIM-E gene, and the we sequenced, we detected the resistance plasmids and sequenced them. And the main form was this 4.83 base pair plasmid, but there are some modification to that we could also detect, but it is also with this NIM-A gene and ISBF6 pair, which this for which there is a distance, constant distance, and from this we just deduce that the IS element NIM gene proportion is first introducing and then enters to the cells. For fluoroquinolone resistance, there is the changes, the mutations in the GRA, GRB genes and can be mediated by efflux pumps. And for tetracycline resistance, the main action is the TETQ gene carried on conjugative transposons, and the action of the TETQ gene can be induced by tetracycline, and it also enhances the conjugative activity of this conjugative transposon. And there is a slide of multi-drug resistance on among anaerobes. So we detected some strains that were also CFIA NIM-B positives, harbored the IS1186 gene and the IS446 genes, and it turned out to be clonal. And in Prevotella species, there are CFXA genes that resemble to the Bacteroides situation, and the in Prevotella boreonii, there are the NIM-E gene and some NIM-K gene are in other Prevotellae. And for Clostridia difficile, we can show that MLSB resistance can be coded by RB gene and can reside in mobilizable transposon. For metronidazole resistance, it's all sometimes heterogeneous, and some NIM-E genes can be also found. And as a summary, we can just say that Bacteroides strains are the most resistant anaerobes. They are rich in antibiotic resistance genes, which are regulated frequently by IS elements and sometimes by two-component protein regulation or attenuation. Attention to be paid to MDR strains, and if possible, antibiotic resistance surveys or individual IST should be carried out, and this diffusion will be a cheap standardized method to detect IST among anaerobes. So sorry for the delay, and now I can finish with this picture that it is a heterogeneously resistant strain, metallobetamyl producing strain. And if you have a question or some interest in our research, you can connect with me in this email address. Thank you very much.
For the wonderful presentation. And we have received some questions. First, I will ask Dr. Brook. But there is one question that what is the best sample for the tonsillitis? Like, because it is difficult to, when we are taking the surface samples, and that may have normal flora. So how to obtain tonsillar tissue, or like what is the best sample for the anaerobes in tonsillitis? Dr. Brook, if you can reply to that.
The best sample is a sample of the core, of the tonsils.
Okay.
What you do, you cut the tonsil down, but you take the blade, you under Bunsen blade when it's hot, you cut the tonsil with a blade that is warm, and then you cut it through, and in the center you scoop the specimen, and then you culture it right away.
Right. So what Dr. Brook is saying is that to take the core tissue, and we can use some hot loop or something to sterilize the surface and then penetrate through that, and then try to take the tissue from there. So I think this is very important to understand. Next, I want to ask is that, is there any cases of Lemierre syndrome reported from USA? Because we had a case of Lemierre syndrome in India, where we isolated E. coli drug resistant 3 times, and we never thought of, like, we were never sent a sample for an culture. But later, when the patient was not responding, we asked them to send the anaerobic culture, and we could get fusobacterium from the blood as well as from the tissue. So what is your experience with Lemierre syndrome?
Lemierre syndrome is all over the world. That is in United States as well. And most of the research is done now in Denmark. They study the fusobacteria and Gloverum, the main organism, but know that many other organisms can cause Lemierre syndrome, not only fusobacteria necrophorum.
Okay. So Dr. Brook is saying it is not just the fusobacteria or the E. coli which we experience. There can be many other bacteria, anaerobic bacteria, which can be there. And there may be a kind of polymicrobial etiology, if I understand, both anaerobes and aerobes, and mostly anaerobes. So I think there is a need, if at all we get a case, usually a child with lymphadenopathy, with hemolytic symptoms and in the blood, and inguinal lymphadenopathy, throat infection. So one should think of this rare disease and try to look for do anaerobic culture of blood as well as the throat swab or the tissue, whatever we get. So I think these are important things to remember when we are sending samples, because most of the time we are just getting aerobic cultures. And if nothing grows, or if it is patient is not responding, then only we think of sending the sample for anaerobic culture. So I think the need of the RA is that simultaneously sample should be sent in both aerobic blood culture bottle or anaerobic blood culture bottle, or both, like we have now Bactec bottles or Bactialert bottles, where the sample can be incubated in a way, and we can, after incubation, can look for culture on both media. So I think that will be very important. If we are not having cultivation techniques, then of course one can go for molecular techniques, but that will be a little cumbersome with most of the laboratories not having those facilities. We have some questions. Thank you, Dr. Brook. Thank you, and for waking up for so long to reply. I will just see if there are any other questions. There is one question from Dr. Colney that this is for Dr. Soki actually. The Bacteroides fragilis metronidazole resistance that show in vitro but does not detect NIM gene for PCR, or the other way around. Like the metronidazole resistance is there in vitro, but there is no NIM gene detected by PCR. So how do we interpret such cases?
Yes, yes. So in that case, we can expect that the redox potential in the cell can be altered. So it can be just with reduced ferredoxin levels, so they can reduce less the metronidazole, so it can act. But for resistance, it is the other situation. So uh, uh, more. Uh, uh,
Can you say something? Please speak loudly, Dr. Soki.
yeah. So in that cases, lactate dehydrogenase activity lowering or pyruvate ferredoxin oxidoreductase enzyme activity increasing can be expected. I showed in my so no. So the redox potential in the cell can be altered, and it causes the resistance, and it can be mainly mediated by lactate dehydrogenase and pyruvate ferredoxin oxidoreductase. We can just have this picture about these resistance mechanisms. It is not very well examined. There are some publications with this, but with some Viennese colleagues, we are working on this to clarify the exact role of NIM genes in resistance of metronidazole or resistance of Bacteroides, or just complement it with these other genes or genes involved in the redox potential.
Okay, thank you, Dr. Soki. There is another question for you, which says that is there any prevalence of antimicrobial resistance in anaerobic isolates from bacterial vaginosis cases? So do you have any such experience?
No, unfortunately not. So maybe you may know that it's polymicrobial and not very well characterized. We just know that it is the altered vaginal flora dominated by many anaerobes causing this, but I don't know any empiric therapy for this or antimicrobial resistance among these pathogens.
Okay, thank you. There is another question for Dr. Brook. One is, what is the basal medium used for preparing carbohydrate fermentation media for anaerobes? What media are you using for testing the carbohydrate fermentation? I mean, any particular media, or because in India we were using peptone yeast extract and then adding the sugars in that and using another indicator rather than using the Andreads indicator, which we use in aerobic fermentation test. We were using bromothymol blue or other indicators because of the very small amount of acid which is produced. So we try to select those kind of indicators. So what is the medium being used there in your experience?
We do the same thing.
Okay. Okay, good. So, so the same peptone yeast extract is the fermentation medium which is being used. Then there is another question for you. Have you got any experience of anaerobic endocarditis?
Yeah, we do have endocarditis. By anaerobes, it's not very common. But the major organisms are Peptostreptococci and Bacteroides fragilis.
Okay.
I have a review about it that I published about 10 years ago in anaerobes.
Yeah. So the person who has asked this question about the anaerobic endocarditis, Dr. Navina, there is a very good publication of Dr. Brook on anaerobic endocarditis. Please refer to that. And he is saying that mostly they have isolated Streptococci and Bacteroides species, We have our center have a good experience of having some Clostridia and Propionibacterium acne, which we have recovered from endocarditis cases. I will be showing some of these cases in my presentation. There is another question regarding any incidence of, this is again for Dr. Brook, any incidences of increased anaerobic infection in post-COVID patients you have experienced?
Not really. We do have some patient with aspiration pneumonia and lung abscesses, and also more Clostridia difficile colitis in those who got antibiotics.
Okay. So he has experience in aspiration pneumonia, especially because patients are usually either on ventilator or having severe respiratory symptoms. So which is leading to aspiration pneumonia, and their anaerobes are playing role. There is also role of Clostridium difficile. We will have a talk by Tina Chopra tomorrow on Clostridium difficile in endocarditis. She has reported in emerging infectious diseases. And also there are few, I mean, one case of Fusobacterium I've seen in COVID case. Again, it came in emerging infectious diseases. So frankly speaking, I think the limitation has been that we are not able to culture these samples from COVID patients, like because the main focus is on the virus and kind of treating the patient, and it becomes very difficult to collect samples from cases who are either intubated or on ventilator. So getting a right sample for culture itself is a very big challenge. I mean, we can get the blood maybe in cases where we are sending blood cultures. But if we are talking specifically collecting any samples from respiratory secretions for anaerobes, I did not see any study, but I think there is a need. And if it is feasible, one should look for that whether anaerobes are increased or whether because of so much of antibiotics being given in COVID cases, whether we are getting more of other anaerobic bacteria which are resistant to those antibiotics. So that area is still not very much explored, and not many papers have come so far in the literature. Show me another question. So there are some more questions which I'm coming to. Then there was also a question, what is the significance of isolating Gardnerella vaginalis from urine sample where urine pus cells are absent? I don't know, I mean, if any one of you can answer that. Any significance of isolating G. vaginalis, the Gardnerella vaginalis from urine sample where urine pus cells are absent?
And usually it could be a contaminant.
Yes, yes. I fully agree with Dr. Brook. I also feel it is a vaginal flora, Gardnerella vaginalis, and mostly it is seen in the vaginal discharge or in such condition vaginosis. So if you are getting in urine, isolating in urine, it is a contamination coming from the vaginal flora. And especially if there are no pus cells, I don't think we can have any clinical significance of that sample. So that is another question which has been asked. Then, yes, a very good question. Any anaerobes which are responsible for lymphadenopathy in axilla or inguinal region? Partly we have answered this question in Limnius, but any other anaerobes Dr. Brook, you have encountered in lymphadenopathy, axillary or ground lymphadenopathy? Because in India, we think tuberculosis is the main cause. So what are the other causes you can?
It's called hidradenitis. Hidradenitis. We did a study on hidradenitis, which we published about 15 years ago. And you can find it in the axilla. And it's usually skin flora, Streptococci, and Propionibacteria acne, and a few cases with Bacteroides fragilis.
So very rightly said, Dr. Brook has informed that it is mostly the skin flora which can come. It can be Propionibacterium, Peptostreptococcus, but he has also recovered Bacteroides fragilis from such cases. And I think there is a need, because we should not just stop on, again, isolating aerobic bacteria, or if it is turning out to be tuberculosis negative, no mycobacterium is isolated or done by PCR not detected, one should look for anaerobic bacteria and treat accordingly, because somewhere you are giving treatment for 9 months in tuberculosis, and here if you have any other cause, you can treat the patient with just 1 week or maybe 2 weeks antimicrobial therapy, which can be, one can do the antimicrobial susceptibility test and give accordingly. So I think there is a very important question, and one should really look for these anaerobes, because unless you look for, you won't get anything. And most of the time we are not even sending the samples for anaerobic culture. So I think sending, first of all, recognizing the importance that these organisms can be there, and simultaneously sending for both aerobic and anaerobic culture, and using our newer methods of cultivation, as well as Malditov wherever it is available, or Vitek if it can be held. But nothing can match your conventional biochemicals, because at times I'm so sure that my isolate is this particular anaerobe. Well, Malditov may give me something else. So I still believe that conventional biochemical tests and conventional identification should be always done, and we should not just depend on the rapid tests, which are rapid methods which are available these days. We must do some comparative studies if the data is not available, and then go for that. Tanu, you have any questions which you would like to ask Dr. Soki?
Yeah, I want to ask Dr. Soki, is there any good automated system for drug resistance for anaerobes? Do we have any system available for detecting the antimicrobial resistance in anaerobe?
I don't know about automated systems for antimicrobial susceptibility testing of anaerobes. I would recommend the MITS test strip method, which is very cheaper than the other e-test method, and it can be done on agar plates. So
Sir, and on which kind of
which media? What are you asking, Tanu?
Yes,
hello?
yes, we use Brucella, supplemented Brucella media for.
Another question.
Okay.
Yeah, Brucella media, yes.
So Brucella agar is the.
The question was, sir, that in which kind of, yeah.
Tanu, your question, please repeat your question. It's not clear.
I want to ask another question. Like, we don't do antimicrobial resistance routinely. So in which kind of diseases we should go for it? Especially in our country, very few labs do antimicrobial resistance for anaerobes. So in which kind of diseases we should not avoid it, we should go for it?
I totally could not understand.
So Dr. Tanu is asking that since it is not possible to do drug resistance for anaerobes in all the laboratories or in all the isolates, it is technically demanding. So what are those conditions, anaerobic conditions, in which we should go for antimicrobial susceptibility? Or what are the anaerobes in which we should go for antimicrobial susceptibility?
Yes. So life-threatening infections, sepsis or like that, or any other severe cases that the clinician wants to get resistance data. I would say this.
So most of the life-threatening conditions, sepsis, septicemia, or where the patient is not responding, even if you are giving Matrigil or some of those antibiotics which are covering anaerobic bacteria, I think one should look for anaerobic resistance. Mostly it is Bacteroides, Prevotella, which the data he has shown. Even in Clostridioides, I must say that in Clostridium now we are getting so much of drug resistance. Earlier that was not a big problem. So I think these are some of the indications. And especially in Clostridioides, I think mainly because when we are looking for hypervirulent strain, and sometimes we don't have methods to look for binary toxin or even for the TCDC gene and look for mutations. So one of the one of the way could be to look for ciprofloxacin resistance, and then go into detail whether it is NAP1 strain or hypervirulent strain. So I think in such conditions you will need to go for antimicrobial resistance or antimicrobial susceptibility for anaerobes. But of course, now agar dilution method remains the best. But if you can have, you can even use e-test where it is possible, and use a special media for when we are testing antibiotic susceptibility for anaerobes. As I said, he has already said Brucella agar is a good medium, and there are some other mediums available. So I think we are running short of time, and we are already exceeded the time. Thank you so much. With my real gratitude to Dr. Brook and to Dr. Soki, we will end this session here. Thank you so much. Thank you. Some of the questions which could not be taken will be taken at the end of the session today, because we could not cover all the questions. So we will take that at the end of the session, or they can be written to the speakers by email, and then we can get their replies. Thank you so much. So we will proceed with the next session now.
Thank you so much, Dr. Rama Chaudhary, Dr. Tanu Sagar, Dr. Brook, and Dr. Soki for this informative session. Now I invite the chairpersons for the next session, giving insight into the anaerobic infections. Can we have the slides, please? Dr. Beena Antony, Professor, Microbiology Department and Head Microbiology and Infectious Diseases Section, Father Muller Medical College, Mangalore, Karnataka. Ma'am has over 88 research papers published in index journals, majority of them related to anaerobes. She has 34 years of teaching experience and has been being a recognized PhD and PG guide, and she has guided many postgraduates, PhD research scholars in various aspects of anaerobes. She has conducted many national hands-on workshops on anaerobes, sponsored by the ICMR, ASM, for postgraduates and senior staff. She has obtained various grants on anaerobes from Rajiv Gandhi University of Health Sciences, Bangalore, and the KFIST grant from the Vision Group of Science and Technology for infrastructure development for anaerobic section. Her areas of research include B. fragilis group and resistance genes, C. difficile, orodental and female genital tract infections, biofilm detection in anaerobes, as well as microbiome. Dr. Srujana Mohanty, Additional Professor in Department of Microbiology, All India Institute of Medical Sciences, Bhubaneswar. Ma'am has worked in AIIMS Delhi as Senior Resident, Senior Research Associate, and then as Assistant Professor in VMMC in Safdarjung Hospital, New Delhi. She has more than 20 years experience in the field of microbiology and has many publications related to anaerobic bacteriology, mainly on Clostridial infection, Propionibacterium acne, and Actinomyces species. She has keen interest in working on anaerobic bacteria and has established the anaerobic bacteriology lab at her institute. Now I request Dr. Beena Antony and Dr. Srujana Mohanty to kindly chair this session.
Start considering the slides now. Slide ID.
Good morning, everybody. Clostridioides difficile has been implicated as the most common cause of pseudomembranous colitis, antibiotic-associated diarrhea. The outbreaks of hypervirulent strains is a matter of concern. The epidemiology of the organism has been changing over the last decade from being a nosocomial pathogen to a community-acquired one. Though a handful of studies from India reported the prevalence of Clostridium difficile, still the toxigenic profile of the strains prevalent in our country remains as a mystery to be unearthed. The present talk by Dr. Rama, the person who contributed a lot in the field of anaerobes in India, especially to Clostridioides difficile, will give a clear picture of the Indian scenario. Her latest case report on Clostridium difficile from intracardiac vegetation appears to be the first article from the world itself. I'm so privileged to introduce Dr. Amma, whom I'm associated for more than 2 decades. Being the international ambassador of American Society for Microbiology to India and a keen researcher, she does a lot of effort to promote the interest in anaerobic bacteria by conducting CMEs, workshops in other institutes sponsored by ASM. Though Dr. Amma is familiar to the whole of research fraternity, and Dr. Swati introduced her twice, for the sake of those who missed out the inaugural session, it is my duty and privilege to introduce her. Dr. Amma Chaudhary is the professor and head of the Department of Microbiology, All India Institute of Medical Sciences, New Delhi, India, as everybody is aware of. And she is the international ambassador of American Society of Microbiology to India and member of ASM Ambassadors Leadership Circle. A few of the awards obtained by her include the Indian Association of Medical Microbiologists Endowment Award, then Dr. Sengupta and A.M. Savoji Memorial Prize Gold Medal, S.S. Kelkar Gold Medal, Lifetime Achievement Award of Indian Association of Mycoplasmologists, and Indo-US Professorship Award by American Society for Microbiology. And about her professional achievements, she guided more than 30 MD, PhD, and DM students, and she has authored over 200 research publications in journals of international repute, including Nature, Lancet, and BMJ. Her signature will be seen in all areas of anaerobes, such as Clostridium difficile, human microbiome, probiotics, and bacteriophages, metagenomics, and also special bacterial pathogens such as Mycoplasma, Rickettsia, Lyme disease, etc. So with these few words, I present Dr. Amma Chaudhary, the chairperson of Anaerobic Forum of India, who contributed extensively in the field of anaerobes, to deliver the speech on Clostridioides difficile and Indian experience.
Actually, the Clostridium was not a big problem a few years back till, in Canada, a superbug was reported, and which actually covered the whole media talking about infections caused by Clostridium difficile. It was known as Clostridium difficile earlier, and leading to so much of death. So this became a kind of, so many hospitalized patients, elderly, reported death due to some unique strain of Clostridium difficile. Next. So in 2008, we were, when we published an article, the media brought out this awareness that one should not just take any antibiotic just like that, because there is a antibiotic associated diarrhea. And that is what was highlighted, that it is so important to have antimicrobial stewardship before we take any, any antibiotic. Only once it is indicated, then only it should be taken. Next. So if you see in today's scenario, I mean, even CDC in September 2013 itself made at the hazard level where it requires an urgent intervention was Clostridium difficile. Even before CDC considered carbapenem resistant Enterobacteriaceae or drug resistant Neisseria gonorrhoeae or many other bacteria which were in this list. So coming to the this particular problem of antibiotic associated diarrhea, where there is a disturbance in the normal colonic microflora, and which is usually leading to the bacterial degradation, alterations in bacterial degradation, and multiple mechanisms are involved. So if you just see the history, initially when it was first thought that there is some colitis which is occurring, it was thought to be Staphylococcus, and later on in 1970, it was seen that it was a clindamycin colitis. So wherever patients were receiving clindamycin, they turned out to be having this particular colitis. And Leighton Bartlett and co-workers demonstrated the cytotoxicity in tissue culture and enterocolitis in hamsters from the stool sample which they have taken from case of pseudomembranous colitis, and the Clostridium difficile was isolated. So the organism itself, as the name suggests, difficile is difficult to grow. And everyone had a tough time growing this bacteria, though before I started, Dr. Usha Gupta was already culturing Clostridium difficile in our lab at AIIMS. Next slide. So if you go to just a definition that basically it is the passage of 3 or more unformed stools in an 24 hours, when we are talking about this definition after taking antibiotics, and whether it is positive for toxigenic C. difficile, then only we consider as the C. difficile being the etiological agent, or getting a histopathological findings on colonoscopy and doing colonoscopy and seeing these pseudomembranes. These are the areas where it is indicated to look for these organisms. So yeah, so if you see that if you take a total of antibiotic associated diarrhea, there are 10 to 25% of cases who may be having C. difficile as a causative agent. But if it is antibiotic associated colitis, 50 to 75% of the cases may be due to C. difficile, and almost 90 to 100% of cases of pseudomembranous colitis are associated with C. difficile infection. So most of the time, there are certain host factors which are playing important role, which we have seen even in the Canada outbreak, which occurred, and later on so many states of USA reported, and then even Europe reported these strains which were unique. And this is mainly advanced age, more than 65 years of age, where it is more common. And most of the time it is associated with some comorbid condition. Patients having, especially these patients where there is a NAP1 strain. NAP1 strain is a unique pulse field gel electrophoresis when PFG pattern is seen in this particular strain, which I said was reported from Canada, which was producing 20 times more toxin. So in such cases, you will find that comorbidities are very important. If the patient is on tube feeds, or if patients having immunosuppression, either because of IBD or because of some immunosuppressive treatment, or any malignancy which is associated, or stem cell transplant. All these are the important host factors which may lead to the acquiring C. difficile infection, and many times acquiring a toxigenic strain, the virulent toxigenic strain. So most importantly, we all know that it is the exposure to antibiotics. So what are these antibiotics doing? So the high risk antibiotics are fluoroquinolones or 3rd and 4th generation cephalosporins. So these cephalosporins are actually responsible for killing the normal microflora of the intestine, and thus leading the small number of Clostridium difficile which may be present to proliferate and therefore lead to the disease. This is one way when the infection is coming from endogenous route, but there can be exposure to C. difficile spores in the hospital settings or in the treatment facility, where the spores can remain viable for months. And the contamination in the rooms where the patient has been earlier there with the active CDI disease, these spores can lead to a contamination of hands of patients or personnels, healthcare personnels, and this can be then transmitted to other patients if the proper hand hygiene is not done. Now, another reason of another important risk factor is gastric acid suppression, which is occurring usually by taking certain proton pump inhibitors, and PPI has been greatly associated with acquiring C. difficile infection. And most of these reports I mentioned has talked about that how these risk factors can be important in acquiring C. difficile infection. So what is this Clostridium difficile? Though I don't want to take a lecture here, but I thought I will just introduce because many of the participants may not be knowing it. It's a gram-positive spore-forming bacilli, and which I said is the most common cause of hospital-acquired diarrhea. It has been seen that C. difficile infection almost result 3 million cases of diarrhea and colitis in US and maybe more. And the case mortality has been shown to be 1 to 2.5%. Next. So if you see this, what is the spectrum of this syndrome? So they can be just simply asymptomatic colonization, where the patient may not have any symptoms. Then they can be mild to severe diarrhea. They can be colitis, where the pseudomembrane is seen. They can be toxic megacolon, and once it becomes severe, they can be colonic perforation, peritonitis, and even sepsis, acute abdomen, and can lead to death in 1 to 3%. Now, this is how pseudomembranous colitis looks like. If you see, patient will present with abdominal cramps, fever, leukocytosis. There will be thickening on CT and widely spread punctate yellow plaques, which you can see in this picture. They are seen on endoscopic examination. And most of the time, patient will give history of taking antibiotics. It may follow antibiotics like clindamycin, cephalosporins. And most of these cases, as I said, are C. difficile toxin positive. So if you see the pathophysiology or pathology of C. difficile, once the organism enters into the stomach, there can be vegetative forms, and most of these vegetative forms are killed in the stomach. But it is the spore which can survive the acidic environment, and they will go through the small bowel, and the C. difficile spore will germinate in the small bowel. Upon once they are exposed to these bile acids, they multiply in the colon, and gut mucosa will facilitate its adherence to the colonic epithelium, and that's where it stays and proliferate and lead to the infection, especially when the antibiotics have already killed most of the normal flora of the intestine. So if you see here, once the bacteria invade, you can see on the left side at one that there is just the bacteria which is adhering to the epithelial cells. This is mucosa and blood vessels. But once the mucus keeps on accumulating, there will be infiltration of these polymorphs, mucin, fibrin, a pseudomembrane will be formed. There will be necrosis of these epithelial cells, and this will lead to the penetration of, these translocation of these neutrophils and monocytes, and ultimately leading to the formation of pseudomembrane. And this is what you will be seeing when you are seeing the pseudomembranous colitis in the gut. Next. So if you see that, so what are these? What are the reservoirs? Though it is said in healthy neonates, it can be there even if there is no infection in 15 to 70% of cases. Less than 3% of healthy adults may harbor, and many patients who are hospitalized with and having antibiotics will have, and it can be there exogenously. We can acquire it in the hospital environment or even in the healthcare worker hands. So what are those antibiotics which can lead to the to predispose to CDI? Mostly it is clindamycin, ampicillin, amoxicillin, cephalosporins, and then sulfa, macrolides, and less commonly rifampicin, tetracycline, which have been associated with CDI. So if you see, sometimes patient comes to the hospital quite well and comes with a problem which is nothing to do with diarrhea. So here it is shown a case which is very interesting, where a patient comes with some injury, fracture, and here in the hospital, the healthcare worker, if that healthcare worker is not using appropriate gloves and handling the patient without taking precautions, the patient actually develops diarrhea, and it leads to a condition where patient acquires the C. difficile from the environment, from healthcare worker, and actually leads to hospital-acquired infection in such a case. So very important that once we know that it can be transmitted by healthcare workers, so important to take all the precautions, which because of COVID, I think we have learned much more than we understood it earlier. The use of gloves and use of all the personal PPE and all the precautions, hand hygiene. And this is where the importance comes. So all these, epidemiology changed when this epidemic strain came, which is 20 times more toxic, as I said. This is quinolone resistant, and it has also acquired a new toxin, which is called binary toxin. Next. So if you see the pathogenicity of the Clostridium difficile, it has an exotoxin A, which is enterotoxin. It has a cytotoxin, exotoxin B. We all know about that. But what we don't know, or maybe we were not knowing earlier, was another toxin, which is known as binary toxin, which is present in these NAP1 strain, or what we call it as Superbug, or what we call it as unique strain of Clostridium difficile. Now, another important thing which happens is that there is a gene which is called TCDC gene, in addition to A and B gene. So if you see, this gene develops a 20 base pair deletion mutation. Because of this deletion mutation, the control on the regulation of difficile toxin production is lost. And therefore, the toxin which is produced, whatever amount is produced normally by a Clostridium difficile organism, once the mutation occurs at this region, then the toxin is produced in much higher amount, because the regulation of TCDC gene is lost on the other two genes, which is TCDA and B gene. So this is how the toxin production becomes more, and this is how the pathogenicity of the C. difficile strain, or what we call it as unique strain, increases. And this is where the changing epidemiology role came. Worldwide rates increased. It became more severe disease. It started affecting young patients. Earlier, we were only talking about the older age group. Now, even the younger patients were coming with serious underlying disease, and where patients didn't even have any hospital exposure prior, for 3 months also started reporting this infection. Treatment failures became very common. It becomes very hard to treat such cases. And the colectomy rates increased, and more CDAD related deaths were seen with such changing epidemiology. So this is the strain I was talking. The full name is B1 NAP1, which is a PFG based typing. Then this is the ribotyping O27, and there is something called as toxinotyping, and it belongs to toxinotype 3. So this is how the strain emerged from 2000, which was resistant to fluoroquinolone. It has an extra toxin, binary toxin, and increased production of toxin A and B, and more severe cases. Next. So this is just showing the data from that time. Before I go to Indian studies, that in 2002 in Montreal, they reported such cases, and 14,000 cases of nosocomial infections were reported, and 30 hospitals in Quebec reported more than 15 per 10,000 patients having this particular infection. And in just in one hospital, Sherbrooke Hospital alone, the incidence of CDAD was much higher, if you see, in 2003 as compared to the earlier years. So I think the only good part of this epidemic was that people became aware about the anaerobes. They understood the importance of C. difficile, and something where the anaerobes were hardly given any importance. Because of this unique strain, and because of the mortality associated with this, more and more people started working on it and unraveling the the pathology associated with that. So, when we come to the CDI diagnosis, first, of course, is the culture, which we should do. And then we have certain glutamate dehydrogenase test available, which is a good test for screening. We can do ELISA. And earlier we used to do cell culture neutralization assay, but now most of the time it is replaced with PCR or with real-time PCR test. So if you see the strategy abroad, they're just using GDS screening first. And if it is negative, they don't proceed further. And if it is positive, they go for either enzyme immunoassay, where they go 3-step algorithm, and then go for PCR if it is negative, or they go directly to PCR. And if it is positive, then patient is treated. I just want to tell a little bit about this anaerobic culture, because this is kind of different than aerobic culture. You need a selective media. You need to incubate the plates in anaerobic medium, in anaerobic jar, or in use gas pack or use glove box, and confirm the growth by simultaneously culturing on aerobic and anaerobic plates. And this is selective media, CCFA, cycloserine, sulfoxetine, fructose agar. which gives the specific colonies. This is how it looks like. Next slide. So next. So, and now we are using in India, prefer to use both ELISA and GDH simultaneously and then go further for the testing. So coming to the Indian scenario, if you see that in 1994, there was a publication by Dutt P. et al., where they had done some 111 cases. And then from our hospital, we did a prospective study and we reported 15% incidence. Then Gogte et al. Reported 18% incidence. And there are other people who have been working. In another study where we did 5 years retrospective study of 524 cases, we reported the incidence was decreasing, maybe because of the presence of the antimicrobial stewardship and because of the availability of the hand hygiene and other stringent measures which were taken that time. Next slide. So this is the first paper which we reported in 99 and talked about this with 15% incidence. And then we also reported the characterization of these Clostridium difficile. That time we did not have too many molecular techniques. We simply did restriction fragment length polymorphism and STS page. And further on, we kept on increasing the typing methods. This we reported, as I said, in the 5 years, how the incidence was decreasing over the period. And it became 4% in 2005 and 2006. From 11% it was in 2001, and which we felt was mostly because of making this awareness and starting improved antibiotic policy in the hospital. Next. And these are, I also want to tell that sometimes even enterotoxigenic Clostridium perfringens may have important role in diarrhea. This also, one of my student, Lovely Joshi, did her thesis on this and published the role of Clostridium perfringens. Yes, next. So this is the latest we have done coming to the MLST. This is a multi-locus sequence typing. And this typing is based on 7 housekeeping genes. And based on these 7 housekeeping genes, we were able to assign certain, what we call it as ST types. And we could identify almost a good number of ST, 35 isolates we have taken. And these isolates we had from 2000. So from 2000 to 2019, these isolates, representative isolates were taken and 12 different STs have been reported. And you will find that some of the ST types have only been observed in our study. That is, one of them is ST17. Although from USA, it is ST1, which is predominant, ST1 type. Then we also reported from 2011, some new types are reported like ST10, ST37, which has emerged in our area, which have never been reported earlier. And the unique part of the study is, if you see all the data, most of these strains of 2000, 2003, which we had 14 strains, have not been tested anywhere in the world. So first time we have done this MLST, and all these unique sequences have been deposited in the EMBL gene bank. And they are kind of, the paper is actually under submission. We have still to go for the publication. So this is how we could assign the dendrogram using the Bionumeric 7.1 software. Next. And this is the minimum spanning tree, which is showing that each strain is depicted with the particular circle here, which shows you how the strains were very different. Only good part is that so far we have not reported any epidemic or even outbreak of C. difficile. So whenever there is any case which is found to be positive, immediately the clinicians are reported and all the precautions are taken so that no hospital acquired infection occurs. And we have been successful. We have not reported any outbreak of C. difficile in our hospital over the last many years. So this I just wanted to tell because Clostridium sordeli is another organism which looks very similar to C. difficile. We reported this case, very unique case of constrictive pericarditis with pyopericardium, where we isolated Clostridium sordeli. Next, please. We also had another case of infective endocarditis by C. sordeli. And if you see the problem comes, next slide. So here, most of the time, sodalite is discarded as a contaminant. So unless you are sure that the tissue which you are getting is collected under all aseptic precautions, because in the beginning when we were getting these strains, we used to go to OT, collect all the samples from OT, from all sites, whether some contamination is coming. And we actually ruled out all possible sources of contamination. Only the tissue which was collected with all aseptic precaution was found to be harboring the, we were able to grow the strain. So when we are growing these strains also have toxin, C. sodalite, and can look very similar to C. difficile at times. So therefore, we started using PCR and ruling out whether they are negative for C. difficile with C. difficile primers. And there are specific primers available for C. sodalite to look for the toxin gene of the C. sodalite. These are some of the cases reported by septic shock, abdominal pain, postoperative necrotizing colitis, and others, where people have reported C. sodalite infection, but endocarditis was not reported so commonly. Then we have this new case which has come. This came in just 2 years back when we isolated Clostridioides difficile from one intercardiac vegetation. And it was a huge vegetation. And then this patient was, and in fact, the identification of organism, we have to at least confirm it 3-4 times by MALDI-TOF, by VITEC, by PCR. And even we have now sequenced the strain and trying to deposit the sequence of all the MLST sequence of this strain also. So this is an eye-opener that one should think of a expanding spectrum of Clostridium difficile. It may not be Clostridioides difficile. It may not be just diarrhea or pseudomembranous colitis. It can occur from blood in sepsis cases, and from blood, even if it is not recovered at times, it can go and lead to any infection anywhere in the body, including heart. So that was what we wanted to highlight. Then there is another publication of Dr. Chetna Vaishnavi. She worked in PGI Chandigarh, where she has shown that Clostridium difficile infection was more common in cases of pancreatic carcinoma. And they showed high incidence in such cases. There is another publication, a good work has been done by Dr. Bina Antony, where they have shown in large number of cases, almost more than 500 stool samples they have analyzed. They have shown the prevalence of toxigenic C. difficile, which was almost 12 or 13%. And so if you see our prevalence earlier was almost similar, 10 to 15%. But again, I can say in between we had declined, but now we are getting again high number of C. difficile isolation. And therefore there is a need to keep looking for these infections. So this presence of toxigenic C. difficile in Mangalore was also a matter of concern, and she really created awareness. She has even tested, I'm not able to show all her work, but she even tested many of the molecules of herbal origin to look for the antimicrobial activity against C. difficile. Next slide. This is another paper where they have done toxinotyping. This is the only paper from India where they have done the toxinotyping. We are doing mostly MLST and trying to look for the NAP1 strain by doing the sequencing of TCTC gene and looking for binary toxin. So this is where they have done the few strains, toxinotyping was done. Next slide. So we were also talking, it is not just now hospital acquired infection. The problem is coming to the community now. So this is very, very surprising, with no history of hospitalization, many of the time no history of even taking antimicrobials in some of the cases. It is becoming common to get this community-acquired C. diff infection. And in 1984, first report came. Then Relay et al. Reported 580 cases where they had 10% of patients who never visited hospitals. So from where they got this infection, it was difficult to trace the source. And then there was CDC reported a series of severe CDI cases in population where they were at low risk, including healthy persons living in Philadelphia and Pennsylvania. Next. So these C. difficile infection in community, if you see that you were seeing a household member with active CDI where there is no exposure at all. So this gray bar is showing where there is no exposure. So this is where the concern is coming. It is not just now nosocomial infection, it can come from anywhere. So how to manage, though the management will be taken in detail by my next speaker, he will be talking about treatment part, but just to quickly tell that antimicrobials are the one which are responsible, and we should not we should not have misuse of antimicrobial agents or antibiotics. We should have very judicious use of antibiotics, and the exposure and acquisition of the C. diff can be stopped. And this can be possible when we are optimizing environmental cleaning and hand hygiene. So if you see, just want to show you that, please remember, nowadays we are using alcohol rubs all the time, sanitizers. They are not good for removing C. difficile, though they may be very good for corona. So in this randomized trial of soap and water, wash with alcohol hand rub, they have shown that soap and water are more effective in removing C. difficile spores. So here, clinician's gloved hand, after he touched the groin of the patient who was having C. difficile infection, is shown where you can see the typical colonies, because the patient, the healthcare worker or the doctor did not wash hands after touching the groin of the patient, and directly it was inoculated on this plate to show you how these organisms can look. So strict adherence to glove use. I'm sure all of us are doing this in pandemic time. And hand hygiene. This is very important, to use all the 6 steps of hand hygiene thoroughly to actually take care of this for the patient safety. Next. So this part I'm leaving. Metronidazole still remains the drug of choice. And now patients are even treated probiotic. This is given usually along with the antibiotics. The reason is when we are giving a combination, then the chances of developing antibiotic-associated diarrhea is much less. And next, a new antibiotic, fidaxomicin, has been introduced by FDA. And this is proving to be a good agent, especially in severe C. difficile infection or even in recurrences. New data is emerging where people are able to work on bacteriophages on Clostridium difficile. So this slide is showing a lot of work which is going on in this direction. Even the bacteriophage endolysin as a potential weapon to combat C. difficile infection has been reported, in addition to bacteriophages which have been recovered. The last conference we held on antimicrobial resistance, we had a speaker also on who spoke on bacteriophages in C. difficile. Next slide. So to summarize, in India, it is very important not to neglect this disease, and kind of wherever the stool, suspicion is high, the stool should be tested. There is no need to, of course, treat asymptomatic disease, but whenever epidemic strain appears to produce more toxin, or where there is a severity, or where we are getting predisposing factors or risk factors, one should think about C. difficile and try to send for culture, and as well as for ELISA or rapid tests are now available. So being the primary cause, there is a very, very important need to screen C. difficile in our cases of AAD. In India, we still do not have the exact incidence because very few laboratories, we can say at AIIMS, at PGI Chandigarh and Mangalore, Dr. Beena is working, few workers are working in Manipal, Dr. Padmaja and Vellore has done some studies. And so some of the other workers are working in Mumbai also. But what is important is there is no national data available. So the incidence of AAD needs to be monitored on regular basis. Regular surveillance is required. And also there is a need to do genotyping and molecular characterization to detect this more virulent strains. Newer modes of therapy should be considered. And very important to have need for collaboration and hand-holding, because people really don't know how to culture or look for these. And the whole idea of forming this Anaerobic Forum of India was to foster younger faculties and students to develop interest in this neglected yet very important field and contribute ultimately to One Health, because C. difficile, I didn't mention, is very important as a foodborne pathogen also and can come from animals. And agriculture can be another problem where the animal excreta is there. So One Health becomes that. For One Health approach, it is very important to kind of collaborate with veterinarians, agriculturists, and kind of exchange ideas and information available with us. Next slide. So I would like to acknowledge, first of all, Professor Usha Gupta, my mentor, who actually helped me to start anaerobic field in my life. Then NIH USA to give me grant, Indian Council of Medical Research for our MLST work, Department of Biotechnology for testing some of the probiotics in C. difficile infection, and Department of Oncology and other University of Maryland and AIMS intramural grant. Thank you so much. So this is my lab, a crowded lab, of course. And thanks to all my technical staff and to all my students who worked with me on this field. With this, I would like to end my talk. Thank you.
Thank you, ma'am, for the wonderful presentation and adhering to the time almost and unearthing the many mysteries on Clostridium difficile. So I think in the discussion session, we will have the questions. Thank you, ma'am.
Hello, everyone. I take this opportunity to invite Professor George M. Varghese for his talk on spectrum and treatment of common anaerobic infections. It's a very clinically relevant topic, interesting, intriguing topic, and we look forward to hearing it. Sir is professor and head of Department of Infectious Diseases, CMC Vellore, and he is extremely well known in national and international scientific circles as a renowned infectious disease specialist, having received his ID training from reputed international schools such as Wayne State University, USA, and London School of Hygiene and Tropical Medicine, UK. Dr. Varghese has received many prestigious awards and honors, including Country Ambassador of the Royal Society of Tropical Medicine and Hygiene, National Award for Excellence in Clinical Research, Senior Fellow, Wellcome Trust, DBT India Alliance, Fellow of Infectious Disease Society of America, and many more prestigious awards. He has more than 80 publications, both in national and international reputed journals, and has held key strategic positions as Vice President of the Clinical Infectious Disease Society of India. He has been an expert committee member of Indian Council of Medical Research of Tropical Infections and expert member of Indian Society of Critical Care Medicine. He is also affiliated to many scientific societies. So we welcome you to share your valuable experience with us. Welcome, sir.
Good afternoon, everyone. Thank you, Dr. Srujana, for those kind words of introduction. It's a pleasure to give a talk on this unusual topic. This is not something which we often discuss. And you know that it is not because it is not relevant. There are several challenges. As you are aware, the proportion of anaerobes in human microbial flora is quite large. It's predominant. If you look at the ratio of number of human cells to the bacteria, what we harbor is about 1:10. When you look at the anaerobes to aerobes, anaerobes is much more in large bowel, for instance, it's probably 1,000 times that of aerobic bacteria. However, there is a huge challenge because culturing this and establishing the etiology and understanding the role it plays in several infections has been a challenge. But over the past several years, the metagenomic approach and several newer technologies have actually helped us in overcoming this challenge. If you see this beautiful picture on the bottom of the slide, it looks like a beautiful garden. In fact, this is taken from PNAS publication in 2016, where they have used fish hybridization technique in identifying these anaerobic organisms. Each of those different colors are different organisms. Those white ones are Actinomyces, for example. So this is from a dental plaque, the hedgehog fish picture of anaerobes from a small dental plaque. So you can imagine the amount of anaerobes which we harbor, and therefore there has to be a lot of clinical challenge. What we don't often think about is, how do we recognize them? When do we suspect these infections? And what is the spectrum? As we have already heard, some of them are quite life-threatening and some are chronic indolent infections. We also have the challenge of endogenous anaerobes causing the infection, as well as the exogenous ones. There are certain clinical syndromes where you would always consider that anaerobes are part of the etiology. Many of them are polymicrobial infections, and you will deliberately cover for anaerobes in those situations. And then, of course, the antibiotic therapy and is there a concern for resistance? This has already been discussed quite a bit in detail. So in the next 20 minutes or so, I'm trying to cut short my whole lecture just to give you the flavor of when would you suspect and what is the spectrum and what's the common approach we take in terms of treating this, to give you an overview rather than going into too much of details about minute details and evidence, because you know that there is a huge lack of data in many of these areas. So when we talk about the anaerobic organisms which are part of our normal flora or the mucosal membranes, we know that they actually are common closer to the, it's part of the gut mucosa, the female genital tract, and the oral cavity. Therefore, most of those reside in these areas. And there are anaerobes in other parts as well, but majority are in these areas. These anaerobic bacteria are, as I said, a major part of the human gut microbiota. And the oxygen is toxic to these anaerobes because of the absence of enzymes such as catalase, superoxide dismutase, and peroxidase. The spectrum can vary from chronic indolent infection and local abscesses to acute life-threatening infections. Some of those I will try and give you examples and demonstrate how do we think about this entire spectrum? The diagnosis requires a clinical suspicion, particularly because unless you think about it and send appropriate samples, including taking the appropriate sample and transport it and do the appropriate anaerobic culture or maybe other techniques to establish the etiology, you're never going to establish the diagnosis. And we also know that most of these are endogenous infections which originate, but we also have the challenge of exogenous ones resulting in the infections in human beings. This is just to impress upon you the ratio of anaerobes to aerobes. Just concentrate on some of these areas such as the terminal ileum and the colon, 10 to the power of 3 to 1 anaerobes to aerobes. Again, gingival crevices and female genital tract, so on and so forth. So we must understand that these are already there. When there is a change in ecology, it could be a mucosal break in the barrier, it could be change in the flora itself. All these can become quite relevant. So when we say anaerobic bacteria, we mean obligate anaerobes, which they cannot survive in the presence of oxygen. They acquire the energy only by fermentation, as opposed to the obligate aerobes, which cannot survive without oxygen. And for the energy, they use respiration, which gives rise to several ATPs. The typical example of Pseudomonas aeruginosa and Mycobacterium tuberculosis. And you also have the facultative anaerobes. Most of the bacteria will belong to this group. Now, when we talk about the endogenous infections, these are anaerobes either in the flora or intestinal tract or the female genital tract, infections arising closer to these mucosal surfaces. Exogenous infections, of course, acquired from the environment, such as Clostridium tetani, also the Clostridium difficile, etc. You could also get the gas gangrene, for example. Most commonly what we see is as an exogenous infection, but occasionally, for example, somebody with a colonic malignancy, Clostridium septicum, bacteremia, and developing gas gangrene is something which one may have to think of. So there are, these can be either endogenous or exogenous. What are the risk factors? This particular retrospective analysis, they looked at a huge number of samples which are established with culture, and they looked at the risk factors. Majority of them were in the elderly age group who had mucosal breakdown, abdominal surgery, or immunosuppression, some form of cancer or invasive cancer therapy, bone marrow transplant, or pre-existing heart or kidney liver diseases. Some of these will give rise to increase the risk of these infections. Now, just to give you the spectrum, this is a case which we had seen, I had seen this several years ago, actually. This was an 18-year-old man who was admitted with chest pain and breathing difficulty and fever. He actually developed sore throat 5 days prior to admission. He noticed an external swelling on the left side of the neck. It was a diffuse swelling. However, he came to the hospital because he developed severe chest pain and associated breathing difficulty. Although he was getting paracetamol and some antibiotics, his disease was worsening. When he came in, he was quite sick. He also had abdominal pain, and there was no other comorbidities or illnesses in the past. You can see that he was quite ill-looking, toxic, febrile, tachycardic, tachypnic. He was icteric. He had a small ulcer, 2 into 1 centimeter sized ulcer on the left anterior tonsillar pillar. And he also had some tender lymph nodes in the cervical region on the left side with a diffuse swelling, and few scattered crackles. His abdominal examination revealed mild non-specific tenderness with a mild hepatosplenomegaly. You can see that his counts is elevated. He's got a thrombocytopenia. His LFT is deranged. Probably he is already in frank SIRS. He is bacteremic. You can see that CT cuts of the lung, there is nodular lesions. This cut doesn't show, but in other cuts, you could see that some of them were cavitating. So in this scenario, young man who comes with an illness which started off with sore throat, going on to develop bacteremia, becoming extremely ill with septic emboli in the lung, the first thing you would think of is Lemierre's. Essentially, you have to think about it and you have to look for it. So this is, we got the CT neck done. You can see that this arrow pointing, the left internal jugular is blocked as opposed to the white one on the right side. You can see completely blocked internal jugular on the left side. And of course, the blood culture growing Fusobacterium necrophorum. As you are aware, this is something which was known for a long time. This clinical syndrome of an oropharyngeal infection leading on to the to develop septic thrombophlebitis of the internal jugular vein, anaerobic septicemia, and septic metastasis, such as septic pulmonary emboli. Although this was described first more than 100 years ago, the first large case series of about 20 patients was well documented by Lemierre in 1936 and was published in Lancet. And that's where the Lemierre syndrome comes, where young, healthy adolescents or adults who present with this clinical syndrome, who these individuals are completely, they are immunocompetent. There is this results from the anaerobic organism invading from the oropharynx. As we already discussed earlier, Lemierre syndrome, although Fusobacterium is the most common bacteria causing this, the other anaerobes in the throat can also cause this. These are less common, but it is they can also cause the similar or the same syndrome. So there are typical clinical syndromes where you think of the anaerobes as part of the etiological agent. These are mostly polymicrobial infections. When there is a periodontal infection or a brain abscess, usually the odontogenic brain abscess, typically you will cover for anaerobes as well. Deep neck space infections or neck abscesses, aspiration pneumonia, lung abscess, empyema, all these are anaerobes which are aspirated, resulting in the pulmonary syndrome. Intra-abdominal abscesses originating from the colon or the other parts of the intestine with abscess formation. The role of anaerobes are quite well known there. Secondary peritonitis again is another situation where you think of anaerobes role because there is a breach in the anatomy. The bowel contents are leaked into the peritoneum, and therefore the role of anaerobes there, you would try and cover that as well. So when you're thinking of oral or neck pathology or the pulmonary infections, the common anaerobes you would think of are Actinomyces, Peptostreptococcus, Bacteroides oralis, Fusarium, Prevotella, etc. The red ones are the gram-negative anaerobes, as you can make out. In the intra-abdominal infections, Bacteroides, Bacteroides fragilis is the most common one, but the other ones as well, along with Clostridium and Peptostreptococcus, occasionally Fusobacterium causing the infections. Now, when you look at some of these studies where they try to see the role of anaerobes in the polymicrobial infection, this is one such study where they looked at 634 patients, of whom 514 had culture confirmed etiology. Aerobes were about 39%. This is out of 81%. 81% had culture confirmation, 39% aerobes, 10% pure anaerobes, and 32% a combination. So if you really look at the role of aerobes either alone or in combination, it's the majority. More than half is due to there is a role for anaerobes, and therefore it is important to think about it and cover. And you can see the various anaerobes which are identified. This was, of course, from the neck abscesses or deep neck infections. Therefore, Peptostreptococcus and Prevotella were much more common than the other anaerobes. If you look at the gut pathology, probably Bacteroides will be the most common there. Also, you must be aware of the other end of the spectrum where people present with very prolonged illness. This was a 43-year-old man whom we saw a few years ago, who he had swelling with multiple discharging sinuses over the left lumbar region for 14 years. He actually went around to different places. He was on ATT for 2 years. He had surgery about 13 years ago, and he continued to have problem, and that's when he came over. Before coming here, what brought him to the hospital is developing weakness of the left lower limb, difficulty in walking, worsening back pain, etc. He, on questioning, he also says that he had noticed yellowish granules along with the pus discharge he had noticed, but he gave no history of any GI symptoms such as melena or constipation or diarrhea. And if you see this picture on the top, you can see the multiple sinuses on the left flank, and you can see the cut section of the spinal cord, the lumbar vertebrae totally destroyed, involving multiple roots which are going down to the left lower limb, resulting in the weakness and also the low motor neuron features. Of course, the culture, as expected, you would find that these are actinomyces. The smear itself was gave a clue: thin branching filamentous organisms. In this kind of setting, you will think of actinomyces, which is the anaerobic organism, as opposed to the nocardia, which you cannot differentiate on a gram stain. Very difficult to differentiate. It will look almost the same, but this will grow unless you do an anaerobic culture. You will not establish the etiology. Otherwise, you will have to resort to other molecular techniques to establish that. So when would you suspect an anaerobic infection? Infection adjacent to mucosal surfaces, as we have discussed, and whenever there is a foul-smelling discharge, necrotic gangrenous tissue and abscess formation, there is when you see free gas in the tissue, but you must be aware that all gas-producing infections are not anaerobes. E. coli, for example, can produce gas in the tissue. So that is not very specific, but these are some of the clues where you would think of anaerobic infections when in the appropriate setting, you would look for the anaerobic etiologies and you establish the etiology. Infections related to tumors or other destructive processes, infected thrombophlebitis like the case which I described, infection after bites, again, although it is not uncommon because most people receive tetanus toxoid, etc. The tetanus due to dog bite or other animal bite is rarer, and tetanus as such is much uncommon these days. Sulfur granules in discharges caused by actinomycosis, the clinical presentation of a gas gangrene. These are some of the clinical clues where you think of anaerobic infections. Also be aware of the exogenous source of anaerobic infections. The typical toxin producing ones, which is the Clostridium tetani causing tetanus, the botulism, and also C. difficile associated colitis. You've already heard a lot about C. diff, and also there is another talk. So I'm not going to talk much about, I'm not going to talk about C. diff at all. I intentionally avoided that. But you must remember that, the Clostridium perfringens, most often it is acquired exogenously. Septicum can also be exogenous, but in somebody with colonic malignancy, suddenly, develops bacteremia and you find necrotic, discolored area with crepitus, underlying features like a gas gangrene, you must always suspect an underlying colonic malignancy due to Clostridium septicum. And the other wound infections and food poisoning, I won't go into the details, just to make you think of the other situations where you consider these. Now, you can also have the acute life-threatening exogenous anaerobic infections. This was a 38-year-old man who had a road traffic accident with a compound fracture of the right distal tibia and a deep lacerated wound over the thigh. The muscle was exposed, the bone was exposed. He underwent a debridement, and they did an open reduction and internal fixation, and patient received IV cloxacillin and gentamicin after the surgery. As you can see, it was they put in the internal fixators. After debridement, everything they have sutured well. The best environment for the anaerobes to survive. Patient develops fever, hypotension, and respiratory distress, requiring inotropic support and ventilation in 48 hours. The repeat X-ray is shown. You can see that there is gas in the muscle, around the knee, etc. And of course, patient had to be taken up again to theater, where they found that there's a lot of devitalized tissue, and the culture, peroperative culture, grew Clostridium perfringens. Again, telling you that the exogenous infection, if you're not aware, in spite of a reasonable care, you could get anaerobic infection. All the more important for you to keep in mind and do the appropriate measures right from the beginning. So when you look at the wounds and the soft tissue infections, Clostridium perfringens is the most common invasive clostridial species, though the other ones such as novae and septicum can also cause the same syndrome. The organism requires damaged tissue with anaerobic conditions, impaired blood supply, and complex nutrients. It produces several toxins, including lecithinase and zinc metallophospholipase, and therefore there is an ongoing destruction of polymorphonuclear cells, myonecrosis, etc. The organism produces gas when they grow. Clinically, you can demonstrate crepitus in some of them, but if there is huge edema, sometimes it's difficult to pick up, but the imaging might help you in that. Penicillin and clindamycin is the usual preferred agent in such kind of settings to cover this. The role of clindamycin is not only covering the anaerobes, this has a toxin mopping up effect, and therefore wherever you think of toxin producing organism, clindamycin does have additional role to play there. These organisms, I mean, I am not going to go into the details of any of the diagnosis, just to give you some thoughts. Unless you think about it and send the cultures appropriately and transport it appropriately, you're not going to establish the etiology. As it is, these are very fastidious organisms, very difficult to grow, and it is not common in most laboratories to perform anaerobic culture and identify these organisms. Therefore, clinical suspicion is crucial. As I said, consider these anaerobic infections in the site of infection when it is closer to the mucosal surfaces such as mouth, gut, and female genital tract, or a foul-smelling discharge, and you can ask for the appropriate anaerobic culture to establish the etiology. These days, the newer techniques such as amplifying and sequencing the 16S RNA gene, and these are becoming more and more common, particularly in situations like brain abscess. What we do is, even if the anaerobic culture does not grow, if you do this, they could be, you can actually target your therapy much better. So some of these newer techniques will help you in establishing the etiology. Now, I'm not going to go into the antibiotic therapy of every anaerobic infection, but I'll try and give you certain principles and overall decision making. On the right hand side, you can see the spectrum of antibiotics which has anaerobic coverage. The most commonly used ones are clindamycin, the penicillins, metronidazole, beta-lactam, beta-lactamase inhibitor combinations, most commonly piperacillin, tazobactam, second generation cephalosporins, moxifloxacin, etc. Although they have reasonably good anaerobic coverage, it is used in very specific situations. The carbapenems are another good antibiotic agent which will help in many of these anaerobic infections in sicker patients. So generally, if you suspect anaerobic infection above the diaphragm, which is near the oropharyngeal region or the lung, clindamycin is a preferred drug there because metronidazole misses actinomyces and microaerophilic streptococci. Below the diaphragm, where the anaerobic infection is suspected, like intra-abdominal abscesses, often we use metronidazole, but you have also heard the concern about resistance. We do not have too much data. Probably Dr. Rama should be able to tell you the details about what we do in terms of looking for metronidazole resistance in those situations. Wherever you suspect that there is anaerobic infection anywhere, beta-lactamase inhibitor combinations are good choices, such as piperacillin, tazobactam. Carbapenems are again good choices. Moxifloxacin, although it can be used for infection anywhere, there are certain reservations. I'll come back to that in a minute. So I'm not going to go into the details of mechanism of action of these antibiotics. You know that already. Just to impress upon you the fact that metronidazole, good coverage for Bacteroides and Clostridium. However, for actinomyces and Peptostreptococci and microaerophilic strep, those are not good agents. On the other hand, clindamycin is a good agent for infections above the diaphragm. The resistance, anaerobic resistance is becoming a concern. What I could make out with the data which is available there, moxifloxacin and clindamycin, there is more and more concern. Moxifloxacin, of course, there is resistance rising, and clindamycin again, it is the proportion of resistance in certain geographic region is higher. Metronidazole and carbapenem are generally lower resistance. There are geographic areas, including Middle East and all that, where they have demonstrated that maybe about up to 10% resistance in metronidazole, in Bacteroides to metronidazole, they might be a concern. Now, the Bacteroides fragilis resistant to carbapenems, in some parts of Asia, there are reports saying, there is a concern, but I don't think it is widely noticed. And occasional metronidazole resistance around 20% from Croatia and Pakistan. In the US, 40% of Bacteroides fragilis and 80% of other gram-negatives are also, becoming resistant. I'm not going to go into the details of the molecular resistance mechanisms, but these antibiotics, when we talk about the metronidazole resistance and looking for the NIM-A or the other NIM genes, and metronidazole resistance probably is the way to check for the resistance in our region. But this clinically, we have not found a significant resistance as a significant concern. Of course, the proportion of infection where anaerobes are clearly established as an etiology is not very common. There are several challenges in answering this question. Just a word about source control and adjunctive treatments. Surgical drainage is often the most important treatment whenever there is an abscess. Source control should be achieved by draining the abscess. The surgical debridement of devitalized tissue, I will be finishing up if that's a bell. The devitalized tissue to be debrided and obtaining appropriate sample is quite helpful in establishing the etiology. Toxin mopping up property of clindamycin I talked about, and also hyperbaric oxygen therapy for gram-positive spore-forming anaerobic rods is controversial. The efficacy is unproved, although people do use occasionally in certain situations. So to summarize, anaerobes are a frequent cause of endogenous infections close to mouth, gut, and female genital tract. These are often polymicrobial infections requiring anaerobic coverage. Certain endogenous and exogenous anaerobic infections could be life-threatening. Recognizing the role of anaerobes in these acute life-threatening infections is crucial and warrants prompt and appropriate treatment. Metronidazole and carbapenem resistance is generally low. Resistance to moxifloxacin and maybe clindamycin could be a concern in certain region. And thank you very much for your patient listening.
Thank you, sir, for your very elaborate and informative talk on anaerobic infections. The questions, there are so many questions are come now, like around almost 30, 34 questions. But I don't know, because of the lack of time, should we go for those questions? Because many of them are to Dr. Rama regarding the questions on the toxins of Clostridium difficile A, B, and also the significance of GDH. Those questions are the
so it's okay. I can answer some of the questions. So Dr. Beena, you can ask the questions. We have,
okay, ma'am.
We will spend 5-10 minutes on this.
Okay. Is Clostridium difficile colonization leading to immunity responsible for the decreased incidence and the symptoms of the disease?
So actually, it is a difficult question in the sense that there is no data to suggest, no study has been done to say that whether antibodies to C. difficile are present there. But yes, definitely asymptomatic colonization has been seen in neonates, they say, and even in some of the adults. But the study we have done in India, where we have tried to see the colonization in neonates, we did not recover C. difficile in neonates in India. Our gut flora is little different from abroad, and we mostly have breastfed babies, and they have a good flora, I think. So that may be one of the reason. But I cannot really comment on it, because as far as the antibodies are concerned, we still need data for that to really know that whether asymptomatic colonization is leading to some resistance to C. difficile infection.
Next question from Dr. Rujita regarding the method used to attain anaerobic conditions, anaerobic jar or gas pack at your place. I think those...
We all, yes, we all started with anaerobic jar, and wherever initially when the gases were not there, we even used to use gas pack. But right now we are using glove box, and that is working fine. And the fourth method of isolating anaerobes is PRAS method, where we use pre-reduced anaerobic sterilized medium. And that is usually done for human anaerobic bacteria, because they are very fastidious anaerobes. So all these 4 methods can be used, and they are good. In private labs, one can use gas pack. So because that is more economical and you don't need gases for that reason. Otherwise, wherever there is a heavy load, the glove box can be used. So these are the 4 methods of anaerobiosis.
Another question, is toxin A or toxin B or both are responsible for Clostridium difficile colitis? And how sensitive is the GDH assay? So I think I clubbed 2 questions.
No problem. So see, the toxin A is an enterotoxin, which will give more like a diarrhea-like picture. But toxin B is a cytotoxin, which invades cells and leads to the pathology. So earlier, there were kits which were either detecting A or B, but now we are getting kits which are detecting both A toxin and B toxin. And actually, it is the presence of B toxin which determines the colitis, or which is actually leading to the infection. So even in the gene expert, you will realize that it is the toxin B. So when we call a toxigenic strain, we are actually referring to the toxigenic strain. We are only referring to the toxin B. So both toxin A and toxin B are important, but toxin B is the cytotoxin, which is the main toxin, which is leading to the colitis. Then we have a toxin C gene, which is more important, as I said, for the deletion mutation to show whether a particular C. difficile is a mutated or not. Then regarding the GDH sensitivity, I think I showed this slide quickly. For the GDH, though the time is very less, but there is almost 60 to 70% sensitivity. And then for the ELISA, it is 75 to 85% sensitivity. And for NAT, it is varies from 80 to 100%. Now, the only problem is if you just get GDH, it will tell you it is a Clostridium, but it will not tell you it is a toxigenic Clostridium. So to know it is a toxigenic Clostridium, you have to do either ELISA to demonstrate the presence of toxin. You can remove it. or you can do the PCR to demonstrate the genes. But demonstration of genes again does not say that there is an expression of the gene. That means toxin is there. So toxin demonstration by ELISA is important from that angle, because it will confirm it is a toxigenic strain. And then, of course, nowadays, as I told you, you can even do the rapid test by GeneXpert, and also real-time PCR for these for the identification. But just using GDH is not toxigenic C. difficile. If just GDH positive, it's not toxigenic C. diff. You need to do the toxigenicity test.
The next question is the role of real-time PCR for the diagnosis of Clostridium difficile infection from rectal swab. Any experience?
I think again, the best and the gold standard always remain as the culture, as far as the C. difficile is concerned. And just even if you do real-time PCR, we are only detecting the genes. So to say it is a toxigenic strain, we should demonstrate the presence of toxin, which can be again done either by ELISA or by tissue culture test, cytotoxicity test, though these tests are not done these days, but those are the ideal methods. So real-time PCR, of course, is a rapid, good test, but that will only tell you the presence of genes. So I don't think it is a good method of demonstrating the toxigenic strain. The culture remains the gold standard still. Toxigenic culture, demonstrating toxigenic strain remains the gold standard.
So one general question, ma'am, any policy measure taken in case of hospitals to culture aerobic and anaerobic culture simultaneously?
Yes, it's a very good question. Although many of the hospitals are not doing it, but I think it is very important. All pus samples should be subjected to aerobic and anaerobic culture, because we are missing many anaerobic bacteria since we are only doing aerobic culture in that. So ideally, all samples should be subjected to aerobic and anaerobic culture, and more so when they are coming. Dr. Varghese has shown very beautiful slide where the indication of anaerobiosis or indication of anaerobic culture was there. So if you go by that slide, you really know what are the samples or what are the conditions where you should go for anaerobic culture. So those conditions, if you are having, or those samples where you are, especially the blood or the pus sample, or any sample collected from sterile site, you should look for anaerobic bacteria, and it should be done simultaneously. So that should be done. So in our hospital, what we are doing now, though it was not done previously, even the blood we are getting for anaerobic culture, and it has been possible to do intracardiac vegetation cultures and all that, because now they started sending all tissues both for aerobic and anaerobic culture. Otherwise, we will miss all these endocarditis cases due to anaerobes. So that is very much requirement, but not many hospitals are doing it due to lack of facility.
One more related question, significance of GDH positive but toxin AOB negative in some patients by VIDAS, that is EFA. So do they require treatment?
See, when GDH is positive means it's a Clostridia, but it is not toxigenic unless you show that toxin A and B is positive. So it will not require treatment. You have to show the toxigenic
carrier state, ma'am. It may be a carrier state or...
See, carrier stage can be by toxigenic strain or non-toxigenic strain, right?
Yeah, that's...
So there can be carrier strain of non-toxigenic strain, but I will not recommend treatment unless there is a clinical correlation. So you have to go by clinical correlation for any GDH test. So ideally now we are getting the method, the strips rapid test where you have GDH line as well as tox A and tox B line. The band can be seen. So if you're getting all the three GDH positive, A, B positive, please treat that case. That is very much indicated. But if it is only GDH positive, it is better to wait for the culture. If you grow some Clostridia, then go for toxigenicity assay, either by PCR or by ELISA, and then go for the treatment. Because otherwise we are over-treating the cases.
The next question is almost covered in the topic. That is what could be the common cause of community-acquired Clostridium difficile infection?
Yeah, that's a good question. I think mostly there are two main things which have been observed. One is inappropriate use of antibiotics, which is very much there in our country, and we have no control on what all antibiotics we keep taking, even for viral infections. So we, in our study also, we have found a good number of cases where there was no hospitalization, and yet they were getting C. difficile isolation or detection by PCR. Another reason is proton pump inhibitors, or the antacids and things we are taking. So that also may be one of the predisposing cause, which is yet to be, I mean, there is no definite data which has emerged, but yes, that is a very important risk factors. And in community, we are even getting the younger people now. It is not just the old age. So all misuse of antibiotics, dysbiosis, which is a very important factor, which can be just not because of antibiotics, because of many other reasons, and disturbed microbiome, all that can lead to community acquired C. difficile infection. I think Dr. Verghese may like to add on this point. What could be the reason, if you want to give your comments, please?
The C. difficile, although we do see it, there is more to understand from our ecology. If you work in a developed country, be it in UK or US, if you go to any ward, you see so many C. diff. But in spite of using the antibiotic using and misusing, like water, in our country, the number of C. diff, what we see is extremely small. So there is definitely additional factors. I mean, I can think of several ones, such as maybe the yogurt is part of our usual diet. The microbiota, there is a difference. And so I think there is more to do with, just the antibiotic use. And therefore, particularly in our setting, we will have to explore and see what are those, resulting in this, or the advantage what we have.
The last one more question, ma'am, that Aarti Sandeep has asked any cases of Clostridium difficile septicemia.
Yes, it's a good question.
Sir, any cases
I have not seen any case of septicemia. I have only seen some.
Sir, maybe no.
Dr. Verghese, have you seen any cases of septicemia?
Yeah, so when we say Clostridium difficile septicemia, if you have to get endocarditis, there has to be a septicemia.
Septicemia, yes.
Yeah, so it is there, but not very common.
Yeah, the septicemia
is the toxin it is actually the toxin which is producing the clinical manifestation, and in a very severe disease, it is toxin related manifestation. But septicemias have been documented. It does occur, and the case which Dr. Rama demonstrated, if you have to get endocarditis, there has to be septicemia.
So what I was trying to say was, yes, definitely septicemia is there, but we have not been able to isolate Clostridium difficile from blood.
From the blood, yeah.
So usually it is transient bacteremia, which is leading to seeding of the tissue, but we have not been able to isolate, mainly because the right sample is not sent. So we do isolation from vegetation first, and then when we tell them, then they want to send the blood, then that time is already gone. So it is important to get the right sample at the right time. Then only you will be able to demonstrate. But what Dr. Verghese said, it's very true. Without septicemia, the organism cannot go from gut to heart. So that is very much there.
So one of the other thing is that if you look at the Western practice, every blood culture, you take a set. And one set is one aerobic and one anaerobic bottle. This, of course, increases the yield. Even when they do that, the anaerobic bacteremias which are demonstrated is much less. And in our country, that practice is not even there. I mean, leave alone sending a set, even to get a blood culture done is a big challenge. So I feel that some of these are because we have not been, we have not been doing what, but especially if you look at the correct setting and you send appropriate samples, whenever you think of anaerobic organism causing the, or as part of the etiology, and send anaerobic samples, invariably you will be able to demonstrate that.
So one question is regarding the clostridial infection in case of trauma with ocular infection.
Yes, we
research?
reported a case of Clostridium perfringens endophthalmitis, which occurred after a penetrating injury. That is long back, maybe 15 years back, we reported this, not with difficile, but yes, with Clostridium perfringens, we have reported endophthalmitis. And yes, there are reports of penetrating injuries of eyes due to Clostridia. That is there.
We had a experience, ma'am, that is one Clostridium novi infection from a retinoblastoma-like infection in a small child. It is supposed to be contacted from soil or something while playing. So that's what finally it was given the report like that. So it was resembling retinoblastoma. And the last question, ma'am, regarding the POC, like periodontal infection, what is a sample to be collected? I think tomorrow's talk, there is a
session tomorrow. We will
session
cover
on this one.
dental infections. We will cover in that. Okay. So we can
sequence. Oh, it's coming one by one. Which method is the best for identification Vitek or sequencing for anaerobes?
We will, the sequencing is, in fact, is the best, because wherever you can do sequencing and identify the strain, this is definitely the best. And if at all Vitek you have, one can proceed with that. It's not the question of what is best, it is a question of availability. If you have Vitek, please do it. Use it to its optimum capacity. And if you don't have anything, and if you can afford sequencing, please go for that. So it is not about best, it is about what you have and how best you can use your resources. That is going to help you.
So
I think we should conclude. Dr. Beena, you will have to conclude the session now. We are already running.
So the last question to Sir, Dr. George. Sir, have you classified treatment strategies for anaerobes above and below diaphragm? Is it based on individual drug actions or the spectrum of activity? This may be the last question, ma'am.
Yeah, partly the spectrum of activities. So that has actually been, I said why is conventionally, we choose that way because if you use metronidazole for infections above the diaphragm, you will miss the actinomyces and the microaerophilic streptococci and all that. So that is why generally above the diaphragm, either BL-BLI combination or clindamycin is a better choice.
Yes.
Conclude here, ma'am, because sir, thank you very much, Madam Dr. Rama. And any further questions you can post to Madam or Sir so that you'll get the proper answer, because there are so many questions coming up now. Because of the shortage of time, we have to conclude. Thank you.
Thank you.
Thank you so much, Dr. Rama Chaudhary, Dr. George Varghese, Dr. Beena Antony, and Dr. Sujna Mohanty for this elaborative and insightful session. From this session, we move on to our next gut microbiome. So in this session, we'll be discussing about the fecal microbiota transplant and the role of probiotics. For this session, I invite the chairpersons, Dr. Aruna Pujari and Dr. Shashwati Nima. Can I have the slides, please? Thank you. Dr. Aruna Pujari is the head of the Department of Pathology and Microbiology and Secretary of the Hospital Infection Control Committee at the Breach Candy Hospital Trust, Mumbai. Ma'am is American Board Certified in Medical and Public Health Microbiology in 2015. After she completed her diploma in the Hospital Infection Control in 2011 from London School of Hygiene and Tropical Medicine and certificate in Infection Control, USA. She delivered more than 130 guest lectures at various CMEs and conferences on health, hospital infection control, clinical microbiology, infectious disease, and laboratory quality management for various medical societies. She has over 38 national and international publications, and her areas of research interest include hospital infection control, antimicrobial stewardship, mycobacteriology, medical education, and quality improvement. Our next chairperson for this session is Dr. Shashwati Neema. She is the Associate Professor, Department of Microbiology in AIIMS Bhopal. She has over 11 years of teaching and research experience and has been actively involved in the field of anaerobic diagnostics and research since 2017. She has established anaerobic diagnostic services at AIIMS Bhopal, which is the first lab serving for diagnosis of anaerobic infections in Madhya Pradesh. She has also been the organizing secretary for first hands-on workshop on anaerobic techniques conducted at AIIMS Bhopal. She has more than 20 publications in national and international journals, and her areas of research include anaerobic bacteriology, antimicrobial resistance, and virology. Now I request Dr. Shashwati Neema and Dr. Anura Pujari to kindly chair this session.
Thank you, Dr. Swati, for the kind introduction. And we now move on to the next session, another very important session for this day and time, that is titled as gut microbiome. And in fact, as more and more knowledge accumulates about the utility and the functions of gut microbiome, I think the next topic is very, very important for us to understand and know. And it is my proud privilege to introduce Dr. Vineet Ahuja. He is the Professor of Gastroenterology and the Associate Dean of Research at All India Institute of Medical Sciences, New Delhi. His areas of interest are inflammatory bowel disease, abdominal tuberculosis, gut microbiome, and gastrointestinal immunology. He has over 225 international and national publications with 24 book chapters to his credit. Sir is the editor of Tropical Gastroenterology. And sir, we are all awaiting to hear from you a very important topic, that is fecal microbiota transplant in GI disorders. Thank you, sir. I welcome you.
Thank you, Dr. Pujari. Thank you so much. And yeah, I'll just share my slides. Yeah. First of all, I'd like to thank Professor Rama Chaudhary for inviting me to this meeting. Thank you so much, ma'am. It seems to be a very, very interesting meeting. Now, the topic which has been given to me is I've been asked to talk about fecal microbiota transplantation in GI disorders. If I look at the exhilarating scientific advancements which have come up, then I would rate this slide as I would say, jaw-dropping advancement which has come up over last 1 year. That is vaccine innovation. Like, this slide is so interesting. Earlier, when we were talking about vaccine development, it used to take 100 years, it used to take 50 years, it used to take 30 years. And we talk about COVID, you find that within less than a year, not one, but many, many kinds of vaccines have been developed. So obviously, it is absolutely stunning. But prior to this, if we talk about what was another stunning advancement, that was the field of gut microbiome. That was like a whole new organ came up, which was always there. But since it was a myth in terms of that you only chase the cultivable bacteria, so as a result, bacteria which couldn't be cultured, nobody chased them. And so much so that gut microbiome is not only into the realms of scientific realms, but it is in the realms of public lay knowledge. Magazines like National Geographic took it up as a cover story. Like, this is January 2020 cover issue of National Geographic. And I'll put a few slides out here, not only because of the stunning visuals which they put up in that article, but also tell you what general lay public knows about this field already. And obviously, when they know about it as healthy people, as patients, because it affects not only people who have a disease, but also healthy people, it affects everybody. So they do have questions for us. So this article talked about trillions of microbes. They affect every stage of our life from birth to old age. And with stunning visuals, it talks about that microbes do not affect only the GI. It is not related to gut only. They affect our health, they affect our weight, mood, even our personalities. They decide, okay, if somebody is going to have a depressive disorder or not. And so many microbes, 38 trillion microbes for a typical young adult. And obviously, if these microbes are having an effect, that's a wonderful prospect of what they use the word tantalizing prospect for putting that inventory to use. And in fact, they went forward in terms of extrapolating. But what I would say is what they're extrapolating is something which is not science fiction. It may be true in another 1 or 2 years. That maybe someday police investigators will go through crime scenes and take samples of skin microbes, much the way they now does for fingerprints. And this article also went on to talk more about science in terms of showing that, okay, you have fecal microbiota and you have mucosal microbiota. And not only that, these microbiota, they interact with the immune system. They interact with the enterochromaffin cells. They interact with endocrine cells. So it is not only that they are present, they make their presence felt too. They make their presence felt through not only in a disease state, but also in a health state. If in through by interacting with the immune system to the dendritic cells, they set up or prime the immune system of the body. If they interact with the enteroendocrine signals, they can send signals to the brain. They can interact with the brain in terms of through the chemicals which are released. And as a result, patients may decide whether they are going to eat more, or the healthy people are going to decide whether they're going to eat more or not. In terms of it is going to decide about obesity. It is going to decide about body mass index. The microbes, when they interact with enterochromaffin cells, they can also dictate whether a person is going to be hurt or a person is going to be happy. In terms, this article showed that there are wide ranging effects of gut microbiome. They are not linked only to the gut diseases. That is, I think, the main message which went across through this article very beautifully. And this article ended up again with a stunning visual and one line that fecal microbial transplantation is a promising therapy. So obviously, when the lay public reads about it, fecal microbial transplantation, and it is going to change the way a healthy person would look to the next 2 decades of life, or how somebody who has a decade with disease moves through the disease, then they want to know about it. And what is FMT? FMT is basically a pan-restorative approach. When you talk about probiotics, you're giving certain strains of bacteria, fine. But when you're giving FMT, it is like a pan-restorative approach. It is infusion of a fecal suspension from a healthy individual into the GI tract of an individual with GI disease. But before we talk about FMT, I would like to delve into one question that dysbiosis. Dysbiosis is whenever the proportions of bacteria or the gut microbiome, the various phylotypes, their proportions are altered. So whenever they're altered, it is known as dysbiosis. So whether the change in gut microbiome is the cause leading to a disease, or it is the effect of disease. And I think this is a very important question, because if we are going to talk about microbiome manipulation therapies, then obviously you would like to know, if you're going to change the microbiome, you would like to be clear in your mind, is the microbiome definitely the cause? So obviously if you change microbiome, then as a result, that cause would be removed or not. So I take the example of a disease that is to answer this question. And since we work on inflammatory bowel disease, so I'll take the example of inflammatory bowel disease. Inflammatory bowel disease, as you all know, consists of ulcerative colitis and Crohn's disease. These are chronic diseases. These are chronic, lifelong, debilitating illnesses affecting people in the when they are prime of the youth and all. And these are illnesses whereby you need to treat patients with immunosuppressive therapy and all. So, along with Professor Jayashree Paul's group from JNU, a decade back, we had looked at what is the real-time analysis. We did a real-time analysis of gut flora for patients with IBD, and took up patients with ulcerative colitis and Crohn's disease. Along with them, they were healthy controls. Fecal samples were taken, and 16S RNA was done. And it was seen that, okay, certain phylotypes, they were significantly reduced in IBD as compared to controls. So we thought that, okay, this is a disease model of chronic inflammatory disease. What about acute infection? Amoebiasis is so common in India. So let's look at amoebiasis, and let us look at what happens to the gut flora out there. And again, we found that it was seen that, okay, there are certain phylotypes which seem to go up, and certain phylotypes, they seem to go down when it came to infection like Entamoeba histolytica. So obviously the next question was, is the signature specific for amoebiasis? And that signature is different from the signature which is for inflammatory bowel disease. Because if there's a difference in signature, that would be the first step whereby you would try to build up the story, whether it is the cause or the effect. And when we compared, we found that, okay, whether the gut signature is different or not, we found the signatures were almost similar for IBD as well as amoebiasis. The dysbiotic signatures were moving in the same vector. So the shift was similar, suggesting that, okay, you have, it's a pan-inflammatory signature which comes up whenever gut dysbiosis occur. So most likely it is the effect. Nevertheless, we still wanted to look for a disease-specific signature. So we took up patients of ulcerative colitis, and you know that short-chain fatty acids are reduced in patients with ulcerative colitis. And so it is felt that, okay, if you, the butyrate-producing bacteria, that's a short-chain fatty acid, if you look at them and we measure them, again, like by 16S RNA, and subsequently also do FISH and measure the metabolites, what happens to patients when they have a very severe disease, or patients who have a less severe disease, or healthy controls? What was seen was, yes, butyrate-producing bacteria were decreased in patients who had severe ulcerative colitis, or who had moderately severe ulcerative colitis, as compared to healthy controls. Again, at the same time, it did not answer a question whether the dysbiosis is the cause or not. And subsequently, another study where we looked at patients who were the sickest, patients who had acute severe ulcerative colitis, who are hospitalized generally. What happens to the gut microbiome signature in them compared to patients who have ulcerative colitis, maybe mild disease, to compare to patients who are healthy? Again, there was a difference in signature, but again, at the same time, it's quite possible all this is happening because of inflammation rather than it being the cause. So obviously, then we thought that let's look at the healthy people. What is happening in healthy people? In healthy people, do you get a uniform signature or not? Because if you want to do FMT, then you would like to first of all decide what are the signatures. So one of our studies was also quoted as amongst the milestones in human microbiota research by Nature, and this study basically looked at healthy people. Now, healthy people, this study was done along with THSTI, and this Bhavatosh Das from THSTI, and this study looked at healthy people. There are no patients in this study. Healthy people who are living in urban areas in Balabgarh, rural areas near Balabgarh, and we picked up healthy people from Ladakh. Why Ladakh? Because Ladakh, we have never seen a case of IBD in the last 15 years, despite going for multiple health camps out there. And so we thought that they are all three healthy groups. So let us see that are they the same, or there's some group which is first amongst equals. And to our surprise, we found that the rural people or the lay people, they had the healthiest microbiome. Although the lay people, they eat a lot of non-vegetarian stuff, they have a lot of stored diet. Despite that, rural and lay scored very high, much higher than urban people in terms of bacterial diversity, in terms of having a healthier microbiome as compared to urban people. So if I put all this, whatever data I've shown you, and I'll put this all in one slide, all I can say is that, okay, there seems to be a stairway. In other words, if patients have very severe ulcerative colitis, they're the worst microbiome. If patients had mild to moderate ulcerative colitis, better than them. Urban healthy, better than them. Rural healthy, still better, or lay healthy, still better. In other words, there's a stairway to a healthy microbiome, yet we cannot be sure that microbiome dysbiosis or gut dysbiosis is the cause of this disease. It could still be the effect of this disease. And I've taken an example of inflammatory bowel disease out here, but let me assure you that when it comes to human data, we still do not have any data available for any disease whereby gut microbiome dysbiosis has been shown to be the cause. Yes, we have animal experiments, we have mice experiments which show that gut microbiome could be the cause, but as far as human experiments, still at this moment, we are not very clear that it is the cause or effect. So why do you want to intervene if you're not very clear it is the cause or the effect? Why do you really want to do microbiome manipulation therapies? Why do you want to do fecal microbial transplantation? The answer to that is that, yes, if you look at this kind of stairway, obviously, and there's a difference in microbiome, whether that is a cause or effect, it does make sense that even though these associations will may be very loose, there is absence of causality, yet it seems reasonable to manipulate the microbiome, because obviously if with a change of microbiome, you can convert a bad microbiome or a person who has colitis, and you can convert that microbiome to a microbiome of a person who is living in a rural area, that similar kind of microbiome. Is it possible? It's possible that the disease characteristics may also change. And so over the years, one can say there are 4 generations of gut microbiome manipulation which have come up. Starting with antibiotics, they change the microbiome or diet. Then you have probiotics. The next talk is on probiotics. Then you have fecal microbial transplantation. And subsequently, we have another generation of gut microbiome manipulation, which is coming up in form of microbiome ecosystem therapeutics. So coming to fecal microbial transplantation, what is the protocol? Is it that something like as complex as bone marrow transplantation? Is it something which also requires, in addition, immunosuppressive therapy because you're going to transplant fecal matter from another healthy person to a diseased person? Well, it's not so. It is much, much simpler. Yet at the same time, there are certain P's and Q's which one has to be very mindful of. So fecal microbe FMT protocol basically consists of, you have to have a donor. The donor has to be healthy. The healthy definition for a donor is very stringent. We'll come to that in the next slide. The donor best is if it's an unrelated donor. All those spouses can also be donor. The workup needs to be done, a stringent workup. Thereafter, you can have fresh stool. You can also have frozen stool that is blenderized with water, 100 to 250 ml of volume, total volume. And subsequently through a colonoscopic route, through an enema route, or through a nasoduodenal tube which is put in. Thereafter, FMT infusion can be done. The frequency, you do it once a week, twice a week, once in 2 weeks, 4 times a month, is all subjective, and we'll discuss that. So most important point out here is that when we talk about a donor, we say, okay, the donor should be healthy. Now that's a very loose definition. All of us on face value would look healthy. But here, when we're talking about healthy, it has to be a very, very stringent definition. In other words, the patient not only should be having any acute medical illness or chronic illness like diabetes, hypertension, heart disease, because each one of them has been associated with dysbiosis. They should not be on any past history in 3 months of taking antibiotics, because we all know antibiotics change the gut microbiome, or antivirals or antifungals, or consumption of illicit drugs, or tattooing, or chronic GI diseases. More importantly is what we're looking at, the donor should also have a good BMI, because we know that obesity is something which is also associated with altered gut microbiome. Mood disorders should not be there in a donor, because we have seen that it has been seen that mood disorders are also associated with dysbiosis. So it's quite possible that if you have a donor with mood disorder, otherwise healthy, you take the gut microbiome, transplant it, for a few years later, for all you know, the recipient may develop a mood disorder related to that. We do not know. So that is why it has the donor screening has to be very stringent. In fact, when we screen, let's say around 30 donors, we end up with only 5 good donors, of which we are really healthy. Not only they are when we're looking for a donor, you have a very good history taking, which is there, but obviously stool testing has to be done for Clostridium difficile toxin assays, or along with that, the fecal microscopy, stool for ova cyst. You would also like to look for HIV, hepatitis A, E, B, C, VDRL and all. And most interestingly, now in the time of COVID times, FMT has taken a little bit of a hit. It has come to a backseat, because as you all know that it's possible that COVID can have fecal-oral transmission, and it has been clearly seen that RT-PCR has been positive, not only in the fecal samples, but also in the epithelial cells lining the gut, where RT-PCR has been found to be positive. So if you want a donor, then you would not only like to test for COVID in the nasopharyngeal swab, but also like to test for RT-PCR in stool. We want to be very sure that the patient is COVID negative, particularly if he or she is a donor for FMT. So donor would subsequently be donating stools, which can be fresh or stored in -80 in a stool bank, and subsequently the sample which is taken, 50 grams of stool is generally taken, added to 250 cc of saline. It is blenderized. Subsequently, large particles are filtered out and thereafter loaded in syringes, 50 ml syringes, 4 to 5 syringes, which can be delivered either to the recipient by most of the cases it is delivered by a colonoscopy, or by enema form, or a nasoduodenal tube can also be put in, and thereafter it can be administered. For example, at our center, we do fecal transplantations very regularly, and most of the time we do the transplantations through the colonoscopic route. So this is just a videos to show that there's a colonoscope, and where the patient is undergoing FMT. There's a case of ulcerative colitis, and subsequently there's a slurry which is there, the fecal slurry is there, which is loaded in syringes, and thereafter it is put through the SS3 channel of the colonoscope, and 200 ml or 250 ml of the fecal slurry is put in. Generally, you go right up to the right colon initially to put in, not in the left colon, because you want the retention time to be more. We started FMT in 2015 in our department. Now we have experience of at least 300 FMTs which have been done at our center, randomized control, but as such we are offering it more as part of randomized control trials for ulcerative colitis and Crohn's disease. And the protocol which we are using it, we are giving 7 sessions at weekly intervals, and thereafter following up the patient. For example, this is a case which is a case of ulcerative colitis, week 0 with a lot of activity on the left-hand side. As you see, this patient received 7 sessions of FMT. This patient was not doing well with steroids, not doing well with other medication. So we put this patient on FMT. This was part of the randomized control trial. And after 7 sessions of FMT, the patient, you see that the mucosa has healed a lot. The symptoms also improved, and thereafter this patient has been followed up as other patients are being, and the patient has been doing well. So what are the indications for FMT? What is a definite indication? When I say definite indication, is something which is FDA approved or in a way internationally approved, or which is followed all over the world. And what are the indications which are still within the realms of research? In other words, they may be offered to patients, but they're still within realms of research. So I would decide, if you're talking of GI disorders out here, then I would say recurrent or refractory Clostridium difficile infection is something which is internationally improved. It's a standard of care, whereas FMT is being done commonly for patients with ulcerative colitis, Crohn's disease, irritable bowel syndrome, and liver diseases. Not only alcoholic hepatitis, but acute on chronic liver failure also. And when we talk about Clostridium difficile, it has become the standard of care everywhere. Globally, it is a standard of care that if a patient has refractory Clostridium difficile infection or a recurrent Clostridium difficile infection, there you do not go in for vancomycin, you do not go in for fidaxomine, you do not obviously go in for metronidazole straight away. There, in that case, you would go in for a session of fecal microbial transplantation, 1 or 2 sessions, and it has been shown to be remarkably successful in terms of results. Up to 90% cure rates have been found, because obviously Clostridium difficile is a kind of acute infection. So there is acute gut dysbiosis. So immediately, if you restore the whole ecology, restore the balance out here, it has a magical effect. And so this is one of the standard accepted treatments for recurrent or refractory Clostridium difficile infection. When we comes to ulcerative colitis, as I told you, there are trials which have taken place. 4 randomized controlled trials have taken place, and all out of those 4, 3 have shown definite benefit. And if you look at the meta-analysis, we find that yes, there is benefit for FMT for inducing remission in patients with mild to moderate ulcerative colitis. The number needed to treat is 5, which is very good result. And in fact, another trial from India, from Ludhiana, showed that not only for induction, if you want to maintain these patients, to give a weekly session of FMT, then also you find that, okay, the results are excellent. Network meta-analysis we did, which is still under review, which looked at, okay, what about the standard therapies which we give for ulcerative colitis? When the patient does not respond to conventional steroid, these patients are put on biological therapies, which are monoclonal antibodies, anti-TNF monoclonal antibodies, or lymphocyte trafficking inhibitors, or Janus kinase inhibitors like tofacitinib. And we were very surprised to see that when we did a network meta-analysis, we found that FMT is as effective as biological therapy in inducing clinical remission, response, and endoscopic remission. Obviously, those are this is a very encouraging result from this meta-analysis, because not only FMT would be much cost effective as compared to these medicines. The general cost for infliximab, adalimumab or something is at least 3 lakhs a year. And then this is also not a finite therapy. There's an infinite therapy for patients with ulcerative colitis or Crohn's disease. So here FMT scores very well. Coming to irritable bowel syndrome, again, RCTs have come up, which have demonstrated some kind of definitely benefit, but again, sustained benefit has not been there. Then for alcoholic liver disease, we have this stunning trial which came up from ILBS, which looked at patients with alcoholic hepatitis who are supposed to be very sick. They have a very high mortality. Generally, the mortality goes up to the range of 50% in 90 days. And here they gave patients sessions of fecal microbial transplantation. There they gave it through nasoduodenal route, and they were able to show a remarkable change in mortality in terms of remarkable decrease in mortality. The mortality was, let's say, 60% for patients who were on regular medication, and for patients of these alcoholic hepatitis, when FMT was given, the survival was 83%. The mortality dropped down from 60% to 17%. These results again need to be replicated. So what is the single major, or what I would say are the major facts which emerge from it? And amongst those major facts, what is the single most important factor which comes out of it? What we get to know is, okay, when we talk about FMT, there are certain things which we need to still answer. That is, what is the best mode of delivery? Anaerobic preparation should be very strict or not, since here, when are you taking up fecal microbiota, majority of it is anaerobic. Should you intervene very early when the disease is mild and when the disease has just started? What is the dose of FMT and all? But I think the most important factor which is out here is that it has has been seen that there's a great impact of the donor. The donor seems to play much great role than envisaged earlier before. For example, when we take up data from the FMT trials, we find that two trials, the trials became successful. Their p-value crossed that line of 0.05 or something just because of 2 or 3 donors, because 1 or 2 donors there were those donors, whenever they donated and FMT was done using those donors, the results were spectacular. The results were very good. So clearly it was the donors which were pushing the success rate of FMT. In other words, there's something called a super donor, and that is a super donor which you need to identify. So when we do FMT at our center, in fact, was a strategy which we are using. Not only we are screening donors and very stringently, but at the same time, we also send the fecal microbiome analysis. And we look if they are rich in Faecalibacterium, Prosnitzi, Ruminococcus, Lactobacilli, Bacilli. Basically, you're looking that if they're rich in short chain fatty acids or aryl hydrocarbon receptor ligands and all, and if they are rich, and if you use the fecal donations from these donors, then what happens to FMT results? That is what we are looking at. Now, let me take you in between to Italy. Italy, this is the ceiling of Basilica of Santa Maria, is a church in Italy. This came in news because this is a huge 4-meter canvas which was on the ceiling of this church, and an earthquake came, I think somewhere around 3-4 years back out there, and the painting dropped. And this canvas dropped out there. So with this was put up around 400 years back, this canvas out there. And when it dropped out there, they saw that at the back of the canvas, there's a lot of decay. And they really didn't know what to do about it, since there was how were they going to restore the painting. And so came up this a publication. They found there was a group which was working on it, where the group which was using microbiota and also probiotics, which could prevent the artwork decay. And so they used this probiotic mixture, they put it all on the back of the canvas, and it seemed that subsequently the canvas was very well protected, and so much so that the scientist in its June 2019 came up with again the lead article that could manipulating the microbiome of artworks prevent their decay. So why I put up this story? I put up this story because gut microbiome seems to have become an all-pervasive theme. It is not a theme which is restricted only to gut disorders, GI disorders. It seems that all systems of body get affected, and obviously this is outside the body, but even in body, let's not be restrictive. All systems of body seem to get affected. No wonder if you look at FMT trials, if you look at the trials which are right now going on, you find that okay, there's a trial going on for bipolar disorder, and this is around 6 months back. I would have picked it up or something. Like if I pick it up right now, there would be even more different kind of trials going on. Bipolar disorder, cirrhosis, malnutrition, Parkinson's disease, psoriatic arthritis. There's a common thread for all of them, which nobody ever thought of. Nobody ever thought of that. Okay, psoriatic arthritis would have a common thread with bipolar disorder in terms of not only perhaps causality, if you can prove it, but definitely right now in terms of treating, you do have a common thread whereby you're altering the gut microbiome and thereby trying to provide benefit. People thought that if you do FMT in patients who have sepsis, who are very sick, who are leukopenic, there may be translocation of bacteria. So people are very hesitant in doing FMT earlier, but came up data from hem-oncology, whereby it clearly showed that immunotherapy colitis, infection, graft versus host disease, whether steroid resistant dependent. We have case series which are coming up and RCTs are ongoing, which have shown the benefit of the FMT even in such very sick and serious patients. Now comes the next point, that how do you regulate microbiome manipulation? In other words, is it possible that FMT may be not be also every medicine is supposed to have an adverse event or a side effect? Is it possible that microbiome manipulation may have side effects? So if you look at various studies which are going on, you find that there are no major side effects. That's what we thought, that okay, transient fever, bloating, diarrhea, flatulence. In other words, no major side effects, as in a patient of ulcerative colitis, if you give infliximab, you can have really life-threatening side effects at some point of time. Or if a patient is given steroids, steroid can cause major side effects over a period of time. But FMT, no major side effect. Yet at the same time, one has to be aware that there are potential risks of transfer of common chronic conditions such as obesity and mood disorders, which I talked about, or certain viral and fungal infections. One has to be careful about it. But more important than that, came up data last year, whereby 2 cases from USA were reported, and this came up in NEJM, where they talked about drug-resistant E. coli bacteremia, which was transmitted by fecal microbiota transplantation. And here they were FMT donors. They had donors who were positive for ESBL E. coli. and two immunocompromised patients who were receiving FMT. They developed this ESBL E. coli, and there was a death of a FMT recipient. So right now, in fact, we've started checking for AMR genes also in the fecal microbiota samples of donors before we go ahead with FMT. Now, next interesting step out here is that we have been talking about microbiota, but the microbiota, how do they communicate with each other? They communicate with each other through metabolites. So are metabolites more important than microbiome? Is it possible that, since obviously the action is being done by metabolites, so what happens to metabolites? And this study from Australia looked at not only the microbiota changes in patients with ulcerative colitis when they were given FMT, but they also showed that yes, metabolic pathways also alter. Short chain fatty acids, they increase. Secondary bile acids, they increase after FMT in patients who have a benefit as compared to patients who do not have a benefit. And at our center, two of our PhD students, Manaswini and Aditya, they're working on it very well. And they're also looking at not only microbiota, but at metabolites at fecal level, mucosal level, and at crypt level to look at what happens to microbiota in patients who are healthy, patients when they have ulcerative colitis prior to undergoing fecal microbial transplantation, and when patients have undergone fecal microbial transplantation. What happens not only to the microbiota, that is fine, that is old news. What happens to metabolites? And this study is slide clearly shows that, okay, this pink is the one which is a control metabolite. These are the untargeted metabolomics which were done. Pre-FMT, you have the metabolomics or the metabolites of pre-FMT ulcerative colitis patients out there. And when patients are given FMT, you see a clear shift in metabolites of patients, much more towards the controls, that is the healthy person metabolites, suggesting that metabolites, yes, they are important. And obviously in future, it may be more important to target the metabolites as compared to the microbiota. Remember that FMT may change the gut microbiota. Gut microbiota is regulated to a large extent by diet. It will be regulated by host genetics for sure, but yes, there are diet. So diet is another upstream, so work can be done on it. And besides that, as I talked about the next generation FMT, that is obviously we want to make FMT, the problem with FMT is the aesthetics part of it. So you would like to make it much more aesthetic and to increase the acceptability. So you have the field of what is known as the live biotherapeutics, which is coming up, whereby we are moving from not only microbiome transplants, but looking at microbial consortia. And in general, groups are working on precise editing of microbiota and microbial metabolites so as to come up with next generation microbiota, genetically modified microbiota, and what are known as ecobiotics. And lastly, I'll add, can't resist from telling this interesting paper, because I feel this tells out that how important the field of gut microbiota has come up to, or how it seems to fire the imagination of scientists. Like Boston Marathon is supposed to be very famous, and obviously it is a tough marathon. So, and Boston Marathon, so what they picked up is they picked up the athletes who were doing really well and athletes who were not doing very well in that marathon, and they took the fecal samples, analyzed the gut microbiota, and they found that in athletes who were doing very well, their gut microbiome was rich in Villanola. And Villanola seemed to make sense because Villanola seems functions via lactate metabolism. So obviously lactate gets stored in the muscles while you're running. And so if you have something which processes the lactate much faster, it would enhance the performance of the athlete. So it was so the fecal microbiota from high performing athletes was picked up, which was rich in Villanola. It was subsequently transplanted. Fecal microbiota transplantation was done in mice. The mice were subsequently put on treadmill, and it was seen that mice who had FMT from those athletes who had high proportion of Villanola, their runtime was not only faster, their runtime also increased. That I would say that's a remarkable story. So to end up, I think for FMT, the key questions still remain that we have been focusing on bacterial populations only. Given the variety of microorganisms found in stool, you would like to focus on viruses, fungi, archaea. You need to look for rationally targeted FMTs, or what I talked about, the super donors. You need to do that. Stool banks with national registry may help. And also the disease state for intervention is very important. Early in stage may be better than when this disease is well set, particularly for chronic diseases. And the conclusions for GI states and the diseases, that is my topic. FMT current status is recurrent Clostridium difficile infection, or refractory to the standard of care right now globally. It is beneficial, safe, and amazing results. Ulcerative colitis, it seems to be beneficial and safe for treatment of active ulcerative colitis, but certain questions need to be addressed before it can be recommended as routine standard of care. Crohn's disease, alcoholic hepatitis, irritable bowel syndrome, you have excellent data which has come up, but yet at the same time, you require much more evidence before you make it a standard of care. Thank you so much for your attention. I'm open to questions. Thanks a lot.
Dr. Ahuja, we will take questions at the end of this session. So I would now like to introduce the next speaker, that is Dr. Vijendra Mishra. So the next topic for this session on gut microbiome is role of probiotics in health. Dr. Vijendra Mishra has areas of interest in probiotics, prebiotics, and functional foods. Sir has about 50 publications in various journals and many postgraduate students whom he has trained and guided, has 11 research projects, with 2 of them being international collaborative projects. Dr. Mishra is a member of many Indian as well as international scientific committees. He has many awards and honors to his credit. To name some, fellow of the National Academy of Dairy Science India. He was awarded as the best oral presentation award at the National Conference of Antimicrobial Resistance from Emerging Threat to Reality, organized by Allahabad Agricultural Institute. He was also awarded a national scholarship of Slovak Republic for mobility of researchers in the year 2006 and 7 under the Cultural Exchange Program, and the Young Scientist Award in Industrial Microbiology by Association of Microbiologists in India in 2004. I would now like to request Dr. Vijendra to please carry on with this session. Thank you.
Thank you so much, ma'am. At the outset, let me thank Dr. Rama Chaudhary for giving me this opportunity to introduce, to talk on the topic of probiotics. In fact, my job has been made very easy by Dr. Vineet Ahuja. I don't know whether Dr. Vineet remembers me or not. I have been treated by you for ulcerative colitis. I was the master's guide of Avina Mishra, one of your PhD scholars. So it's really a privilege to be amongst you all and to talk on this topic of role of probiotics in gut health. Gut health, it has been a huge area. Just now, Dr. Vineet, in a very excellent presentation, gave aspects on this. So friends, I come from this institute, National Institute of Food Technology Entrepreneurship Management. It's located near Singhu border, and it's an institute under Ministry of Food Processing Industries. So we have very good, excellent infrastructure regarding the food processing and pilot plants and food testing laboratory. Having gone to this, some of the initial part of my talk, Dr. Vineet has very excellently, as I said, mentioned. Earlier, we were thinking that we are simply human. But now the concept is that we are not human. And if I say that it will not be wrong if we say that we are more microbe than human. So the concept nowadays has evolved is of being holobionts, the whole perspective of interaction of the human cells, as well as the other cells, as well as their components inside our body. And this has led to this concept to understand that what is gut microbiota, which has huge diversity among us. I'll not go detail into this. More than 1,000 diverse microbial species and 10 times the number of human cells in our body. So, and they are located in every part of our gut. So maybe even though there are certain factors which do not allow their growth, but still they survive in those kind of conditions. And if we look, there are so many phyla which dominate, which are part of this our gut microbiota. But the research says that 2 phyla, Firmicutes and Bacteroidetes, they form the majority of this our gut microbiota. So the question comes that whether the gut microbiota of everybody is same? No. It varies from person to person. Each individual, it may have its own different signature gut microflora, gut microbiota, and that's how, because and this gut microbiota, it plays significant role in different aspects. It has got immunological functions, It has got psychological functions. It provides barrier between what's inside our body and what's outside. Huge role in digestion, huge role in nutrient absorption. So, in fact, every aspect our body, just now discussed that even mood disorders, every aspect of body, it is now linked with the gut microbiota. And IBD has been beautifully described now, but there are in research has shown that alterations in gut microbiota may lead to different kind of health conditions. IBD is prime obesity. It could be diabetes. It could be liver diseases. So the implication of alteration of gut microbiota is huge in human. Now comes the important aspect that how this gut microbiota gets affected right from birth up to 3 years. It usually at 3 years level, it usually stabilizes, but there are so many factors: genetics, birth root, the geography, hygiene, stress, diet. Diet is a huge significance. Drugs. These are all factors which affect the gut microbiota. And if we look that how basically these they exert its impact. In this figure, if you look at here, these are the dotted line shows the input aspects, whatever input we are giving to our gut. And these continuous lines, they show the output aspects. The red one shows the positive and negative aspects, and blue one they show the positive aspects. So there are a lot of negative inputs which we daily give to our gut microbiota, be it excessive consumption of certain nutrients, or be it the drugs like antibiotics, proton pump inhibitors. Then there are certain positive intakes also, dietary, fiber, and probiotics. So this is one aspect, one positive aspect intake which we can give to stabilize our gut microbiota. And today I'll be going to talk about different aspects of probiotics and how they have been implicated through research into the into providing gut health in improving various conditions of gut. But all these positive negative intakes leads to a lot of negative as well as positive outcomes. And that we have to understand that by improving the positive intakes, we can definitely improve these positive outcomes. And if we keep on increasing the negative intakes, the negative outcomes, they are going to increase. So the focus of point is how by manipulating the positive intakes like probiotics, we can improve, and what research has shown throughout that how these probiotics, they are involved in betterment of gut health. So if we look at this, the historical aspects, how the science of probiotics they developed, we all know the fermented foods, they have been part of the cultures, the dietary cultures everywhere, be it Neolithic era, be it the Middle East era, even in our culture also, they are part of our diet. But the scientific basis of the concept of probiotics, the first scientific observation is credited to this man, Elil Mechnikov, who observed that the yogurt is the secret of longevity of Bulgarian peasants. He observed that the people living in Bulgaria and that region, they consume a lot of fermented foods. And basically, they had long life compared to other regions. And he gave, through scientific basis, he tried to interpret that. Thereafter, the big push in probiotics came in 30s, whereby Minoru Shirota, he introduced this a milk drink fermented with Lactobacillus casei, which is prevalent till now. So overall, the whole development of science of probiotics, it coincides to some extent to the development of science of microbiology and its basic concepts, starting from the concept of Louis Pasteur to nowadays, when everything it depends on the gut microbiome and the sequencing aspects, right? And as the science of probiotics, it increased, it enhanced in recent past. Then lot of stakeholders they came into being. Like we scientists, our aim became to generate high quality science. Industry came in place. Industry came in place with a motive to have profitable products, high quality profitable products, which have validated and understandable claims. And hence the regulators also came. Because in between when the 1930s to around 2000, the whole definition of probiotics and all this, it took a lot of changes. So in 2002, the FAO WHO, a joint expert committee was formed. They gave a definition which is the most accepted definition, which says that these are the live microorganisms which when administered in adequate amounts confer a health benefit on the host. So the three underlined words are important. Number one, it said that these are the live microorganisms. That means at the time of consumption, it should be in live form. Then administered in adequate amounts. Consumed word is not used, it's administered word, right? Then in adequate amounts, that means there has to be certain limited amount, right? And third thing, it must provide certain benefits to the host. So this definition encompassed almost all the aspects of probiotics. Another matter is that in 2013, one grammatical change was done by ISAP, but largely this definition has been the most acceptable kind of definition throughout the world. In India also, ICMR DBT gave it certain guidelines, and here lies the crux. Every organism cannot become a probiotic. It has to pass through a lot of tests, lot of steps to become a proven probiotic. Right from starting from the isolation, its identification, then understanding their in vitro properties under in vitro conditions, then in vivo conditions whereby their safety, efficacy is to be established in animal models, and then human trials. Human trials also have to go in different phases for their efficacy, for safety, efficacy, as well as effectiveness. So any organism, any candidate which has to be established as a probiotics needs to go through a very rigorous scientific kind of experiment, whereby to show that it definitely has some kind of effect to show. And then there are foods with related to food, there are labeling requirements. So there are a lot of criteria through which safety criteria, technological criteria, because when we are incorporating it in foods, the food is getting processed, food is getting stored, it goes through a supply chain. How to maintain it in a supply chain? It may be stored in varying conditions. It has to be produced at a large scale, mass scale. It has to be packaged in different conditions. So all these things, technological criteria, functional criteria, when it is going through gastrointestinal tract, it has to withstand each and every kind of hurdle which our GI tract gives. Then there are certain desirable criteria. So a lot of selection criteria are given, implemented before taking any probiotics. These are some of the successful organisms. Lactobacillus is one of them, number of species. Bifidobacterium is another. Then there are other bacteria. And if you look at the last which I have highlighted, it is the Saccharomyces boulardii, the only yeast which is proven to have probiotic properties. Rest of those which are used commercially in either food or drug, they belong to bacteria. Now, having seen these basic aspects of probiotics, how in gut health they are significant. So studies have been done. Lot of studies have been done on specific probiotic related, specific gut related clinical things like irritable bowel syndrome or IBD or antibiotic associated diarrhea. So there have been studies. The crux of some of those studies is presented there, like probiotics like lactobacillus and bifidobacterium mixture that has been used And it has been found that it decreases the IBS symptoms like abdominal pain, bloating, and flatulence. Similarly, for antibiotic-associated diarrhea, it has been found that certain organisms, like certain species of Lactobacillus bifidobacterium, if you see here, a specific dosage has been mentioned that how much of that was fed during the trials, right? They reduce the antibiotic-associated diarrhea. Then acute infectious diarrhea, they have been found to shorten and reduce the duration and severity of illness. So a lot of these kind of information is available, evidences are available, which implicate or which show that probiotics in specific gut-related specific clinical conditions, they can be useful. But there are certain specificities. I would like to discuss certain specific aspects which have now, because of the molecular enhancement in the molecular science and the techniques, a lot of evidences have evolved. One aspect is leaky gut. We understand leaky gut is a condition whereby if the epithelial cells, they are joined together by these tight junctions, and these tight junctions, they are again joined by, there are certain proteins like claudins, occludins, and these proteins are again enforcement is done by proteins like zonooccludins. So the functionality of this gut is significant, because the tighter the junctions here, the more integral is this membrane. Once these proteins, they become looser, the gut, there may be a space here, and there may be, it may lead to a leaky gut, whereby the metabolites can leak into through these cells. So it has been seen that the altered expression and localization of these tight junction proteins, these proteins, it may lead to the condition of leaky gut. So in recent research, certain trials has been done, which shows that these administration of probiotics, specific probiotics, they may lead to the to change, variation in upregulation in expression of these proteins which are involved in tight junctions. Like Escherichia coli nacelle, it was found in upregulation of ZO1 expression and redistribution also. The these three, four are they are primarily trials done in animal models, but this is significant. The last one, Lactobacillus plantarum, WCFS1. This is a human trial whereby it shows that in humans also the consumption of Lactobacillus plantarum, it increases the ZO1 and occludin proteins expression. And that cements our thought that yes, probiotics, they are involved in improving the leaky gut kind of situation. Another mode of action which has been widely discussed is regarding the mucus layer properties. We all know mucus layer, it has significant role in our intestine. It's a protective barrier. It facilitates food passage, and then it also avoid from adhesion of bacteria. And basically this mucus layer, it is primarily made up of mucins, which are high molecular weight glycoproteins. So these mucins, they are critical factor in mucus layer. So specific probiotics, it has been shown through trials that they have probiotic bacterial strains, they influence the mucus layer properties, and the mode of action has been that they affect the expression of these proteins, mucin proteins, like Lactobacillus plantarum 299V. It has been found to enhance the gene expression of MUC2 and MUC3 protein, right? Same way VSL3, which is one of the very combination of probiotics, is a consortium. It has also been found to enhance the gene expression of the mucin proteins. Lactobacillus casei GG, which is one of the most studied probiotic organism. It also has been found not only to enhance the gene but also the protein expression of Lactobacillus casei of mucin, and it also has been found to reduce the E. coli translocation through that gut. Escherichia coli nacelle, it also has been found through trials to enhance the gene and protein expression of these mucin proteins. So that is one kind of a mode of action which has been found in these through these probiotics. Another evidence which has evolved nowadays is that these organisms, they produce a lot of effector molecules. Now, these effector molecules can be either part of their metabolism, these can be byproducts of their metabolism, or these can be part of the surface structure of the cells also. And these effector molecules, inside the gut, they carry out different kind of functions. They have been found to be involved in different kind of functions. Like if we see LGG, which I said is one of the most studied, it produces certain proteins P75, P40, which is found to be involved in prevention of cytokine-induced gut epithelial damage and prevention of colitis. EPS, the exopolysaccharide, which it produces, it has been found in mitigation of adipogenesis. Similarly, other organisms like Lactobacillus acidophilus, NCFM, it produces certain surface layer proteins. And these surface layer proteins, they are found to be involved in modulating the intestinal epithelial barrier. So what the basic fundamental is that these organisms, these probiotic organisms, they produce certain kind of molecules which may affect, which are involved in modulating the expression of some of the proteins or modifying the conditions inside the gut. Another very beautiful case is with the Bifidobacterium. How Bifidobacterium? We all know that Bifidobacterium, it is the one of the initially associated with the infant microflora, and human milk, mother's milk, it enhances the Bifidobacterium population. How basically it has been it happens? One of the mechanism which has come out is the way Bifidobacterium utilizes human milk oligosaccharides. So if you look at here, the mechanism in Bifidobacterium is that this is the milk oligosaccharide. Through its transporter proteins, which are located in its membrane, it completely internalizes this human milk oligosaccharide, and using its glycoside hydrolase enzyme, which are inside the cell, it cuts down and utilizes these oligosaccharides inside. But if you look at other organisms like Bacteroidetes, what happens? They have got this mechanism of utilizing human milk oligosaccharides in their cell wall, cell membrane, and then here the enzymes are located which convert this human milk oligosaccharides into monosaccharides and then release into the gut. Now what happens because of this? These monosaccharides, they are utilized by other bacteria. So a lot of harmful bacteria may also utilize. So their population may also proliferate, which Bifidobacterium is not allowing. So this is one beautiful way how Bifidobacteria is showing that. Then lot of recent effort has been in probiotics regarding their vitamin production, particularly in gut. Through in vitro, in vivo studies has been said that they produce folic acid, vitamin B2, vitamin B12, right? And in one of the study, it has been found that along with riboflavin production, this was done in an animal model, it reduces the intestinal damage induced in the gut. In one of our study, we are working on the riboflavin part of the vitamins. We have also seen the animal trials we have just finished, and there is a significant improvement in the riboflavin parameters when we fed our cultures to the bulbs mice. It improved their aggregate status, FMN, FAD status when with these two indigenous strains when we use in our trials. Another way of improving gut health by probiotics is by inhibiting the pathogens. There are different mechanisms by which the pathogens may inhibit, like antimicrobial activity through lactic acid production, bacteriocin production, which are specific molecules which are produced by them, then competition for nutrients, which is a generalist kind of mechanism, and then alteration in intestinal metabolome. The first two looks very sound in their aspects, while the other two are quite general kind of mechanisms. But yes, there have been examples, there have been research which shows the bacteriocin production is a quite effective mechanism. Now, Dr. Vineet also mentioned about the short chain fatty acids. The probiotics, it has been found that they produce short chain fatty acids because just now, as you mentioned, that there are reduction fatty acids when in IBD kind of patient. So they enhance the short chain fatty acid like butyric acid, which have different effects on the host. And one of the effect is it lowers the pH in gut and then inhibit the other sensitive organisms. Another mechanism which has been prevented in gut is that these organisms, probiotic organisms, they reduce the conversion of procarcinogens into carcinogens. Basically, the anaerobic organisms like Clostridium, they produce enzymes like azoreductase, nitroreductase, which convert procarcinogens into carcinogens. So it has been found that the consumption of probiotics, it reduces the activity of that enzyme, those enzymes, even though it has not been fixed that how that activity is reduced. So there are various kind of approved, which are being studied throughout, and this shows that you see so many probiotic organisms, right? And they have been found to be involved in different gut-related conditions. And I'll say that most of these are animal trials. So we have to ultimately, unless we don't go for human trial, we can't say. But still, there are strong evidences whereby under different kind of conditions, the use of these probiotics, it has been shown. Now, ISAP, with the body of this, they classified how the distribution of mechanisms of probiotics occur. Like there are certain rare effects which are shown by probiotics, which they say, which is very strain specific, like neurological, immunological, or endocrinological. There are certain frequent kind of things, even though I disagree with some of the part, like vitamin synthesis, since we are working on vitamin synthesis, and we have found it's a very, very, very rare kind of effect. When we started with 500 isolates, we had only 2 at the end who were very good riboflavin producers in our project. But there are certain like bile salt metabolism, neutralization of carcinogens. They are some of the frequent kind of actions which have been shown for them. Then widespread actions include their colonization resistance, competitive exclusion of pathogens, regulation of intestinal transit, which may be present among widespread kind of organisms. So that's why for each effect, we have to very seriously see how the effect can be proven in animal models as well as in humans. The market potential of probiotics, it's increasing day by day. In 2018, the US market supposed to be 49.4 billion, and 2023 it is expected to be 69.3, and with compounded annual growth rate of 7%, which is huge. And probiotic beverages, dietary supplements, animal feed products, they all are coming all the way into the market. This is the data for US. And in India also, we are not far behind. Even though probiotic market, it is expected to grow at much higher CAGR than the US market, right? These are some of the players which are there in India, which have launched a lot of probiotic kind of products. So if I conclude, evidences shows that probiotics, they have immense potential in health benefit. Number one, by modulating that microbiota. Number, its activities and thereby influencing the overall health, right? And majority of these claims, but there is a star, there is a condition apply. Majority of the probiotic claims, they still lack the mechanism underlying their action. While we have a generalized kind of mechanisms, but for each we have to have an underlying mechanism. And this makes it challenging to select the right probiotic strain for a specific kind of clinical condition. And this also leads to a lot of debatable issues in realm of the probiotics, like food versus drugs. How should we take it? The food scientists say that food is better because it's a protective matrix. It allows the organism to be protected inside its coating, but drugs are there. Indigenous versus foreign. Whether any probiotic organism which is proven in a foreign country, will it be useful to Indian population, or should we have only indigenous? Our ICMR guidelines say that even if there is an organism which has been studied in foreign countries, until unless its efficacy is not proven in Indian population, it cannot be used. Then single strain versus multiple strain. There are contrasting views on this, how to use, whether single strain is better or multiple strain is better. And finally, quantity. As we saw in few of our study, I showed that there are some certain quantities have been mentioned, but what is that specific quantity? Will it vary to person? Will it vary according to condition? And like recently, FSSAI has given certain guidelines, and in those guidelines, it shows 10 to power 8 live cells. Some people say 10 to power 6 live cells. So basically, what is the quantity which must be taken up for a specific kind of condition? So these are a lot of debatable issues. The science on probiotics is developing. It's developing at a fast pace, but yes, so are developing the issues related with the science of probiotics to take ahead. So finally, we are working a lot on these probiotic organisms, riboflavin and the vitamin related things we are doing, some food products. We are tied up with some international collaborations. The last one which we have initiated is the kind of toxins and pollutants which come in food. We want to see how they affect the gut dysbiosis, how they cause dysbiosis, and can we have some symbiotic preparations to mitigate that kind of conditions. So thank you so much for this opportunity.
Thank you so much for your wonderful presentation, Dr. Bijender and Dr. Vineet. We have certain questions from the audience. I would like to two of you to answer. Is Dr. Vineet there? Yes.
Yes, ma'am, I'm there.
Yeah. So one of the question is how feasible it is to screen the donor for MDR isolates and AMR genes. So what is the strategy to be used and how feasible it is?
So obviously it is not an easy thing in the sense that you have to have multiplex PCR. And in fact, the earlier studies, which one came up from PJ and the other which came up from South India, Pondicherry, which looked at healthy people, enterobacteria resistant. They, in fact, the PJ study initially screened with MALDI-TOF and subsequently did the multiplex PCR. But multiplex PCR can be done, so it can be set up. It's not tough also, but yes, you need a sort of tertiary care center to set it up. But FMT, again, if you have to do FMT, it provides lots of safety in terms for when you're screening the donor stool with MDR genes.
So can you do resistomes? I mean, now the thing is coming up, and since we know that in this particular patient, you have to do FMT. And rather than going on again to isolating bacteria, doing their antibiotic, that is going to be really cumbersome.
Yeah.
So, I mean, of course, it may be expensive, but if you really go for resistome and, really look for the AMR genes, and we are sure then, yes, whether it is there or not, and whether we can proceed with this particular sample. And maybe you store that sample for long and use it for many patients in future.
Certainly, ma'am. That's great.
So I think we will have to go for certain newer techniques now using NGS and look for MDR genes, the way one of the audience has asked this question. Now, next question they've asked is, how is AFMT affected? How AFMT affected the post-COVID era or post-COVID time? Are you still doing it or not doing it?
So first thing is, are we post-COVID for sure?
Yes, not yet.
Are we still through COVID? Still going.
We are through COVID.
So FMT, yes, it has taken a backseat for sure. Everywhere FMT was suspended because of chances of fecal-oral transmission. So yes, but now if you want to do, you can do FMT, but you have to screen the donor for not only with the nasopharyngeal swab, but do a RT-PCR in the fecal samples also, and be very sure that, or the other alternative is do FMT best from spouse. Because if you do FMT from spouse, then you just do a nasopharyngeal and you have the medical history available. Sometimes then the acceptability is much more.
Dr. Prama, can I ask a question, please, from Dr. Ahuja?
Yes, please, go ahead.
Dr. Ahuja, you discussed like short chain fatty acid is essential for the healthy gut. So there are different types of short chain fatty acid.
Can you introduce yourself first?
Om Prakash.
Okay, yes, Dr. Om Prakash, please go ahead.
So what type of short chain fatty acid is very essential for the healthy gut? Because there are a group of short chain fatty acids, 10 to 12.
Dr. Om Prakash, there are 3 short chain fatty acids: acetate, propionate, and butyrate. Okay. Of these, it has been seen for as far as gut is concerned, for colon, butyrate is the best. Right? That provides the maximum health benefit.
And what is the best method to like detect the like short chain fatty acid concentration in the gut from the fecal sample? Because the label will be very, very less. So how can we accurately like quantify that?
So if I get your question correctly, would you like to increase the amount of butyrate in gut? So if you want to increase the amount of butyrate or short chain fatty acid in gut, then one is the dietary methods, that is give a lot of undigestible fiber. So you give a lot of undigestible fiber that is acted upon by the butyrate producing bacteria like Faecalibacterium prausnitzii and all, which leads to increased short chain fatty acids. Some studies, informs if you want to use it as a drug, then butyrate enemas or short chain fatty acid enemas have also been given, but were not found to be very useful. So the best strategy would be to increase the amount of indigestible fiber, which can be further broken down into short chain fatty acids.
Right. So is it that symbiotic will be better? That I mean, if we are not giving FMT, we can give symbiotic.
My only thing is that Dr. Mishra gave a very good lecture on probiotics, and he talked about various aspects of it. My only issue with probiotics versus FMT is that probiotics, you're giving a few strains. FMT, the whole team is going in. Once the whole team is going in, it's quite possible that the quantum is also much more in terms of the number of strains, spores, everything. So, and not only the strains are going in, the viruses, bacteria, bacteriophages are going in, which may be also providing some kind of benefit, it's possible. So that way the chance of benefit are more. You're restoring the whole ecological balance. It's like a forest which has run down, the trees and all, they are not good out there. And you restore the whole ecological balance, and only a few plants are not going to do it.
Yeah, as Dr. Vineet said, like in probiotics, we are giving only either one strain or a combination of 2-3 organisms. But FMT will definitely have more impact. But and one more thing which I could see difference is probiotics you need to take continuously for a duration, while FMT must be a one-time or 3, 4, 5 time procedure, not more than that. So, but the way it is being given, FMT is done, and the way probiotics are taken, we have a very nutritious way of taking probiotics. So probably that may encourage people to take more of probiotics. I don't know what has been the response for FMT when people come to your what must be their fears with respect to FMT.
So I would like to add here one thing, that probiotics are preventive, and FMT is more like a treatment. So I think prevention is better than cure. So let us not go to that stage where we have IBD or we have a requirement of recurrent C. diff infection and we have to go to Dr. Vineet Ahuja for FMT. So let's be happy with having regular good probiotic in our diet. Have your
Right,
good
right.
food, good diet, healthy diet, and be healthy so that we really don't need FMT. But I have one more
And
point. Because the fecal microbiome is real complex. It is not so simple. I mean, it's okay, we are giving FMT, but many times we don't even know what all bacteria are going in that. I mean, including whether drug resistant or drug sensitive. We still are naive in many of our knowledge regarding the total content of FMT, or what you call it as fecal microbiome. And many hidden things are there. You did show 2 reports of E. coli infection causing bacteremia. And in immunosuppressed, there is a question whether we can give FMT in immunosuppressed individuals safely. So with all those concerns, my only worry is that when we are giving single probiotic, most of the time we are giving probiotic having the total knowledge of that strain. We know, we actually fully characterize that strain and then give it. Only problem with fecal microbiota is that it is not possible to characterize all the strains. They are not cultivable. They are, I mean, it's more like a big mixture where many things we don't know. But yes, we are actually depending on the total outcome, because we are getting a good outcome in cases where you are giving FMT, and if the patient is responding, I think it's very good to go for that. But then if you go to the science of it, many things still we do not know, whether it is bacteriophages which is playing role, or there may be some viruses or fungi, also part of normal flora. We have actually not studied all that. And what Dr. Ahuja said, that he wants to look for the viromes and bacteriophagome and maybe resistome, it is still an evolving field. So of course, if patient is cured, we are happy. But if as far as science is there, we are still learning a lot, and we have to keep on exploring and keep on learning.
Ma'am, if I add one thing to it, that I agree with you, but when it comes to probiotics, the science clearly says that you give that particular strain for that particular disease in these many number of spores. Right?
Yes.
So if you look at the studies available, then you'd find that overall you fit in for only 2 or 3 indications in general. For the rest of the things, that kind of, either the strain would not be there or that much amount of spores. For example, for ulcerative colitis, we did a probiotic study with VSL3. We had to give 900 billion spores per day for 8 weeks if we wanted to induce remission. 900 billion spores means 25 tablets of VSL3 at the present state, in the strength in which it is available. So obviously, for whatever way you give, 25 tablets a day is not practical for anybody for 6 weeks.
No, that's why Dr. Vineet, like one point I raised regarding food versus drugs. So because giving as a spore, it has less chances of them going and becoming active there in gut and imparting that kind of effect. And being with food, because food itself is a matrix which protects the organism against the different kind of hurdles which our GI tract pose. So also that is one of the important aspect to be seen in probiotic research, that how to deliver the organism safely.
Yeah, it's more physiological. Diet is more physiological.
So one more thing I want to add, that ultimately we may be giving a mixture of bacteria or organisms, but the effect comes what you were talking about, the metabolites or the metabolomes. So it may be, there may be 100 bacteria, which may be even different otherwise. If their outcome or the product is that particular metabolite which is healthy, say for example, butyrate or any other, then that is what we are actually looking for. So I think when we go to science, we really know that the probiotics or the FMT or anything, ultimately it is going to be what is its metabolic end product and what is it delivering. That information also is evolving. And as I said, that sometimes it may not match, because when we just studied, it's not always, say for example, butyrate can be produced by different kinds of strains of bacteria. So it is not just presence of one probiotic strain or one bacteria, it is what is the outcome or what particular organism's mixture is producing that particular effect. So if that effect is there, the result will be better. So I think it's a really kind of network of different metabolites which is going to make you healthy. And give you good results because it's really complex.
It's a lot of synergistic kind of activities go there. There may be possibility the organism may not produce a compound you produce in lab, but when it goes into that community, then it may produce those kind of compounds. So it's a whole synergistic science which takes place inside gut.
Yes, yes. So quorum sensing is going to play a role, and a lot of things.
Quorum sensing is one, right?
Yes, where the bacteria will talk and decide whether they
Yes.
want to make us healthy or ill. So I think any other questions we have? There were a few other questions. We will just take that quickly. So there was one I have already asked you, what is the role of FMT in immunocompromised patients? Someone has asked, so you won't like to give any specific answer to that?
Yeah, ma'am, as I showed you that there are a lot of trials, case studies going on in hemat-oncology. Patients have graft versus host disease, patients who are going to undergo chemotherapy. So obviously those are the patients who are definitely immunocompromised. Then patients of ulcerative colitis are often on steroids, azathioprine, so they are immunocompromised. So FMT has been done in all those immunocompromised patients with good benefits.
So there is a delegate from Singapore, Dr. Aruna Shani. She has asked, has increased numbers of kids born with LSCS, cesarean, led to more health issues in kids?
Yeah, definitely. It seems so, because when we talked about, Dr. Mishra showed a nice slide where he showed factors which change gut microbiome starting from birth right through adulthood. And the primary factor which has been implicated in neonatal period is what was the route of delivery, vaginal or cesarean.
Yes.
The second is the role of antibiotics in the first 1 year. Those two factors seem to decide gut microbiome right at the onset.
So is there any role of, another person has asked, is there any role of probiotics in hospital-acquired infections such as ventilator-associated pneumonias?
Not from my side, ma'am.
No, not much. I haven't come across any case study or report of such kind of.
Yes, I also agree. I in fact checked with once with our pediatrician, Dr. Kabra, that time, because there were some projects were coming for reviewing if we can use probiotics for ventilator-associated pneumonias, and we were trying to see whether that project needs funding or not. And there was a lot of controversy and a lot of lack of data, we realized, and we actually did not go for it. But I would like to say that yes, there are emerging role of not probiotics or the microbiome I'm talking of, some of the bacteriophages role is coming up in ventilator-associated pneumonia, where you are having a specific drug-resistant Acinetobacter or any other bug like Pseudomonas aeruginosa. And there we are getting that specific phages which may be used in ventilator-associated pneumonia. So the role of probiotics is still controversial or not very well established.
To add to it, ma'am, we are going to starting a trial whereby we are doing FMT in AMR patients in ICU. Patients who in AMR, it's a funded trial from ICMR. So we are.
Oh, wonderful. So I think it will be able to answer many of the questions which these attendees are raising. Another very important question, is there any role of probiotics in patient with lactose intolerance? So this I also get many times, this question, especially in children, lactose intolerance. Can we give probiotics in that? Because it's usually milk product when we talk about. So any suggestion on that?
This lactose intolerance, it is considered one of the generalized effect of because lactic acid bacteria, they have been implicated as probiotics, and it primarily comes through their conversion of lactose into lactic acid in milk product. So they reduce the lactose in the milk product and convert it into lactic acid when consumed. Now, second aspect is a person having lactose intolerance feeding the microbial cells only, and then person taking milk. Whether it will have same kind of effect in that condition, I doubt, because they're taking it through food which has been pre-fermented, which has been where pre-conversion of lactose into lactic acid has been done, and doing it in the gut itself. These two are different kind of conditions. So in fact, hardly I have seen any paper which says that you feed probiotics first and then let person consume milk and then see the efficacy of conversion inside gut from lactose to lactic acid.
Dr. Vineet, you have to say anything?
You need the lactase enzyme. So you cannot do that with probiotics unless until you give truckloads of lactobacillus.
Lactase, yes.
So until then, lactase enzyme is a much better.
Yeah, so I also agree, as in such one has to be very careful, especially with the diet of the children, and it's a big problem taking care of such children. And I think one should not just go for and start feeding any probiotics till the evidence is there, and specific treatment only should be given in such cases. And as far as possible, these should be avoided. Shashwati, you want to say something?
Yes, ma'am. May I ask one question to Dr. Vijendra? Yeah.
Yes.
Yes.
Dr. Vijendra, one question is that is the combination of probiotic changes with different diseases? Means if there is infective etiologies, then we should use this. If we want to use it for treatment, then is there any suggestion for use of probiotic for different kind of GI diseases?
No, the point is, even when we were discussing, even Dr. Rama Chaudhary ma'am's, that it's more of a kind of prevention. As far as complete treatment of any disease, GI disease, despite being a scientist working in probiotics for 20 years, I'll not suggest that you depend only on probiotics for complete treatment of any kind of GI disease. Means ultimately you will have to go to Vineet Ahuja in any case, Dr. Vineet Ahuja in any case, even if you are taking probiotics. So it may reduce the remission, it may reduce the severity of symptoms, but it will completely treat that is not the case.
Okay. And for prevention aspect also, suppose if you want to prevent from some kind of bacteria or some kind of viruses, then is the combination is different of different probiotic? What do you suggest?
Yes, look, most of the effects of probiotics, they are very strain specific. Okay. So ultimately, until unless we don't prove that that strain is having any those kind of effect which we intend to see, we cannot concretely say it, and we must not use that also until unless because specifically in GI tract, these generalized kind of conditions is fine, that reducing the pathogens by competitive exclusion and all those kind of things. But in specific clinical cases, until unless we don't have a proven effect, we must not take.
Okay, thank you.
So we will conclude today's session only to say that a lot of research has been done for probiotics in notobiotic animals where they're totally pathogen free, and then you introduce a particular bacteria and try to develop a disease and see whether this particular organism is going to make the change or not. It is very difficult to see in a state where already bacteria are present and then you want to see the effect of that. A lot of good research is being done in University of Texas Southwest, where a clinician is really working and trying to have the colonies of those mice and small animals where they are doing these experiments before they really say that this strain is going to be effective in this particular condition. So with that, we will conclude today's session, and we have tomorrow again session at 9:30. I will advise all the participants to log in tomorrow at 9:25 itself. We have a talk on Clostridium difficile infection in COVID era. A researcher from USA, Dr. Tina Chopra, will be presenting her data. And also there is going to be a quiz after all the sessions tomorrow. And whosoever wins will get an award. So please be there in time and please attend all the sessions seriously. Thank you so much for all the speakers today. To our guest of honor, Dr. Usha Gupta, to our director, chief guest, Dr. Guleria, for inaugurating the session, and to all my chairpersons and all my colleagues who have really worked very hard to make this webinar a successful program. Thank you so much. We will conclude today's session.
Thank you.
Thank you, Doctor. Thank you, Dr.
Dr. Mishra.
Thank you.
Thank you, Dr.